Okay, it's 1 o'clock. Guess it's time to begin. So thank you everybody for coming here to our meeting on non-pharmacological approaches to the early prevention of AD, ADRD. And before we get started, we wanted to give an opportunity for a couple of our co-hosts and division directors to say some kind words about this. So we'll start off actually first with my division director, the director of the Division of Behavioral and Social Research, Liz Nielsen.
Thanks, John, and hello, everyone. It's great to see everyone today. I just want to say a few words. So both BSR, Behavioral and Social Research, and our Division of Neuroscience support studies to build the evidence base for a variety of lifestyle and behavioral interventions to promote cognitive and brain health and prevent cognitive decline and dementia. BSR specifically supports several programs of research that are relevant for understanding risk and reserve factors for AD and other dementias, primarily, but not exclusively, from observational studies. And there's emerging information suggesting that behavioral patterns or psychological profiles much earlier in the life course than we've previously been studying both are forcing us to think about how we might see real opportunities for earlier intervention and focus our attention on realizing that we really don't understand the causal processes early in the life course that do lead to protection or risk. And so, this workshop is really designed to focus in on some of those issues. For example, in BSR, we've supported a lot of studies that have established that educational attainment is strongly associated with positive cognitive outcomes in later life, but we really don't understand how and why that occurs. And we also have evidence from longitudinal studies starting in adolescence that personality factors measured 50 years ago might be associated with later life dementia outcomes. And also there was a recent 2017 National Academies review of evidence for interventions to prevent cognitive decline and Alzheimer's disease that really highlighted this need to start study years at earlier ages and have longer follow-ups, and noted that most of the approaches that we currently have good evidence for, like cognitive training, blood pressure control, physical activity, are all approaches that require changing individual behavior and sustaining that for many decades. So this study is going to be particularly important, or this workshop particularly important, in helping us discuss what sort of evidence base do we need to build years before disease onset so that we can justify a public health agenda around long-term lifestyle and behavioral change for AD prevention. And I'm really looking forward to both the methodological discussions, the measurement discussions that we're going to have to fill some of the knowledge gaps here in the field that we as an institute can start to examine in the future. So let me turn it over to my colleague, Eliezer Maslia, to just say a few words. Eliezer is the director of our Division of Neuroscience, with which we partner on many of these efforts.
Thank you, Liz, and thank you, John, for inviting me to be here. And also thank you all for joining us today. As Liz mentioned, the Division of Neuroscience works closely with the DBSR on many of the topics that you'll be talking about today. And actually, this workshop comes on the footsteps of the recent Alzheimer's disease research summit that we just had a couple of weeks ago, and last year the care and caregiving summit. So all the feedback, all the gaps and opportunities that you identify on this workshop, I think will be very helpful informing us in the milestones and the next steps that we're developing for our national plan to address Alzheimer's disease. In particular, the Division of Neuroscience, it's really very interested in supporting non-pharmacological interventions for AD, ADRD, in particular as they relate to the prevention of cognitive decline. We support a range of non-pharmacological interventions, including exercise, diet, lifestyle, neurostimulation, cognitive training, and then of course the combinations of all these different therapeutics. Actually at the Alzheimer's Summit that I mentioned we had a few weeks ago, a number of these trials were featured, including the SMART trial that combines some of these cognitive and stimulation approaches, non-pharmacological approaches for dementia, which really we think have a tremendous impact. In fact, many of our clinical, non-pharmacological clinical trials are probably going to be reporting 22, 23, and as you know, in the road to the 2025 timeline for the national plan to address Alzheimer's disease. So I think very exciting results and research that's going to be coming in the next couple of years, and really looking forward to these workshops and what you guys have to say, and learn more about all these exciting research going on in the field. And thank you again, Lisa. And next.
Thank you, Eliezer. Thank you, Eliezer. And next, and last but not least here, the co-host, co-chair of this meeting, Dr. Maria Gleamore from UCSF. She was really, truly important in helping put together pieces of the agenda for such a complicated meeting, decided what we could talk about today and what needed to perhaps be delayed for another day. But thanks very much, Maria. Do you want to say hi or?
Yeah, sure. Thank you very much. I'm really excited about the day. It was this was so much fun to be involved in organizing, partly because the challenge, as anybody who's watched the field, the challenge is incredibly multifaceted. We have difficulties in terms of how do we really precisely define the interventions that matter? How do we think about the outcome assessments that we should be using, both sort of functional outcomes that are patient-centered and mechanistic outcomes that really demonstrate that's how something is working, and conceptualizing how we could design trials in ways that could be more informative than what we often do. We've tried to bring together experts that can give really leading edge perspectives on each of these. I think in some cases, these are people who don't necessarily talk to each other a lot, or at least they're people that I hadn't gotten to talk to very much before this engagement with this. So I really enjoyed thinking about it, and I hope everyone who attends enjoys the discussion as much as I have. And I want to thank the NIA and the divisions for fostering this conversation. I just can't think of a more important topic, so I'm very excited about it. Thank you.
Thank you, Maria. And with that out of the way, I think we can start on the first talk, which is actually a talk by me, which is going to be setting the stage for the meeting. So I'll wait for Derek to get there. Yes, this is me, and this is my talk. So I'm talking today about non-pharmacological approaches to the early prevention of AD, ADRD. That's the meeting title. A little bit about the state of the current science and proceeds of the meeting. And where we start, as Eliezer was pointing out, is essentially our mission and our charge is in fact the recent, the fact that we have these ADRD research implementation milestones. As a side effect of the National Alzheimer's Plan Act, one of the things that we've been doing is we've been listening to expert opinion and from gaps and opportunities developing a set of research milestones, which are in aggregate over the 150 or more of them. We are hoping getting us closer to a point where we have either ability to prevent or to at least to modify Alzheimer's disease and Alzheimer's disease related dementias by 2025. And one specific milestone that was the sort of the impetus for this meeting was this milestone 8D, which is quite daunting. It's to initiate at least one clinical trial for primary prevention of AD and AD-related dementias among high-risk individuals in midlife, including a non-pharmacological treatment arm. Now, it's clear where this is coming from. We have this greater understanding that it may take longer. We may need to start prevention efforts longer and longer before the onset of neuropathology, let alone dementia. But the excitement behind attempting to find these things is balanced against several significant challenges in how one is to construct these trials. So another source of advice for us here was actually a report generated a few years ago by the National Academy of Sciences entitled Preventing Cognitive Decline in Dementia. And this was a report out from National Academy of Science, Engineering, and Medicine activities, taking in a report that was generated by AHRQ and their evidence-based practice centers to attempt to look at the evidence that we had for whether we could prevent cognitive decline, dementia, or mild cognitive impairment. Actually, the dementia they talked about was dementia of the clinical dementia of the Alzheimer's type is what they specifically had in mind. And the NASM committee took the original conclusions, which, by the way, said that we really should not be messaging any of the current things that we might have thought we could say were going to be beneficial, and instead gave us some ideas about how we could construct a stronger evidence base and what areas might be particularly encouraging. So the first was to tailor interventions to individuals at highest risk of decline in dementia. So this makes sense to the extent that we'll talk a bit about it later. Clearly, those who are at the highest risk of decline are at the highest risk of decline. Moreover, your intervention trials are more likely to be able to track change in them than in others. Secondly, as Liz pointed out, we were definitely encouraged to begin more interventions at younger ages and have longer follow-up. This with the notion that because in some cases we would need to intervene years or decades ahead of frank development of neuropathology or dementia, is the way that we were told to move, however challenging it will turn out to be. Finally, or not finally, but they also suggested we use consistent cognitive outcome measures across trials. A constant complaint from evidence-based practice centers, if anyone's have been in other efforts that they've done, is the fact that in many cases, many of our intervention trials, while well-meaning, use an inconsistent set of cognitive outcomes that are sometimes difficult to combine or to meta-analyze. And this was considered a real issue in some cases with combining evidence across trials that might have otherwise generated more positive recommendations. And a new thing, which in 2017 seemed perhaps newer than it does today, is to include biomarkers as intermediate outcomes in more of our trials. The notion being that we would be able to see more information in earlier biomarker evidence than perhaps we would if we had to wait far longer to see actual outcomes in cognition or function. To increase the participation of underrepresented populations to study intervention effectiveness in these populations. As I think we now understand, this is not only to make sure that our interventions generalize, but in some specific cases, it may be that we may need to intervene differently, earlier, or in some other fashion to actually reach communities, many of which are actually at greater risk for Alzheimer's disease and related dementias in the general public. And finally, and this is, again, very difficult, to conduct large trials designed to test the effectiveness of intervention in broad, routine clinical practices or community settings. We will actually talk a bit about this in this meeting, perhaps more than one might have anticipated. So again, the NASM committee also pointed to 3 promising classes of interventions that were deemed the highest priorities for research. And the first was blood pressure management for people with hypertension. Should point out that the NASM committee was meeting before we had the access to the results of SPRINT or to SPRINT Mind. And those results, of course, were very encouraging indeed. And it's actually very fortunate that we're able to get those results because the efficacy of SPRINT itself on its primary outcomes was so great that it was ended early. And it was definitely possible that it therefore would have been in a more compromised position to detect positive outcomes for SPRINT Mind. The second was increased physical activity. Again, this is something that we have heard messaged in public health quite a bit, that exercise and physical activity promote brain health. But what the committee had found was that most of the trials, while there were several promising trials, they were all relatively small. They had different outcomes. They had very different notions of the dosage. And so it was unclear whether or not this data pattern would hold with larger trials. Now, however, we currently have several multi-site RCTs in the field, and as Ellie Zamanslia pointed out, several of these are reporting out in the very near future, and we hope to have a much richer idea of what sorts of physical activity may be helpful in what doses and for whom. And finally, and this I will go into in a little more depth, there was a recommendation that cognitive training be still pursued as a possible avenue for remediation and promotion of brain health. And NA does maintain an active research and clinical trials portfolio in this area, which is seeming more promising at some levels today because of our ability to use modern technology to make these interventions perhaps more accessible and more intensive. So as to the last thing, Back in 2014, the Advanced Cognitive Training for Independent and Vital Elderly, that's the ACTIVE trial, published its 10-year outcomes. And this is basically significant press attention. This is the front page of the Boston Globe. I should point out that I was actually the project scientist for the ACTIVE trial, or rather the last of 4 project scientists. I was on there for the last 5 years of the trial. And I should point out that although we were very encouraged by the results of this, we did immediately recognize that there were still challenges to be overcome. And in particular, although ACTIVE did show 10-year benefits in reasoning, that's the top panel, and speed of processing training, and you can see that the effects of that training was very specific. Okay, reasoning didn't improve unless you got reasoning training. Speed of processing didn't improve unless you got that training. There were some issues. So in particular, those advanced interventions were advanced in the late 1990s when the trial was being designed. And these days we would perhaps choose differently and implement them differently as well. Only the speed of processing training, for example, actually used any kind of computerized training whatsoever. Secondly, the control group was a no contact control group. And although this was a no contact control group that seemed to remain relatively engaged throughout the process and did not differentially attrit, it's still, we understand, an issue, particularly when we're looking at, for example, self-rated kinds of outcomes that a no contact control group would be perhaps inappropriate. Another issue is that ACTIVE was designed actually to improve function in these individuals through cognitive training. And they were looking for people who were already extremely cognitively intact, and that they got. The inclusion and exclusion criteria meant that the participants were very intact cognitively and actually really did not sort of slip as fast as one might have expected. An additional thing is that the outcomes, although were chosen carefully with respect to promoting and supporting function, these outcomes had in the testing large practice effects. And this remains a particularly problematic issue outside of cognitive training trials even. In many cases, our outcome measures have large practice effects, and the interpretation of effect sizes is complicated by the fact that people receiving even a placebo arm will still show improvement. Perhaps more concerning than a lot of things, when you run a trial for 10 years and you run it from 65 to 75-year-olds, you are going to have substantial attrition. So although the ACTIVE trial started with almost 2,800 randomized participants, by the 10-year outcome level, we only had 883 remaining in the trial. So many of the inferences one would like to make about the efficacy and the potential future effectiveness of the intervention are complicated by the fact that the attrition was so great. Moreover, there were other issues that I don't have time to go through, except to point out that despite the encouraging results of the intervention, the mechanism of action really remained unclear. You could sort of understand that training memory would improve memory. How that happened, what it changed, was difficult to determine from this trial. And so when we're thinking in terms of this meeting, we really are looking for the causal mechanisms that would, if you hit them right, would actually result in perhaps the prevention of AD or ADRD. So if we have a trial with a non-pharmacological intervention, we can ask the efficacy question against a specific ADRD related outcome. But what we suggested is you actually start from a blanker slate, instead focus first on a putative target, the thing you're attempting to modify with your intervention. And so if you have a target like this, and you can think of, so for example, perhaps chronic stress has been associated with poor cognitive function, maybe you would like to reduce stress. So you could in fact find out whether or not people report less stress, or whether physiologically there does seem to be less stress. If you were very encouraged about some other piece of outcome, one could wonder if neuroimaging would give you any evidence that something had changed in the structure or the function of the CNS. And as I mentioned, more encouragingly recently, our ability to take biomarkers related directly to AD and ADRD related processes and measure them not merely in central cerebral spinal fluid, CSF, but also in plasma, allows, for example, the possibility to see changes in see changes earlier, because you'd be able to look at greater numbers of individuals because of the cost, efficacy, and acceptability of it. And all of these things in green here are in fact the topics of the first the first part of this meeting, which is all going to be about target engagement. How do we know when a target's engaged? How can we measure that process? The second session is going to be focusing on these ADRD related outcomes. So for example, for the cognitive outcomes, which is what we'll be focusing on in this meeting, clearly you could attempt to use gold standard neuropsychological measures. You could attempt to use lighter weight measures that we might be able to give, for example, in a much larger number of people, could be advantageous for these sorts of prevention studies. Or there may be signs in the environment, in the life of these individuals that are themselves are reflective of changes in cognition. The third segment of the talk here will be actually getting back to the trial design, back to the question of how you find whether things are efficacious or most efficacious. And this will include concerns about what should actually go, and what is often a package of non-pharmacological interventions, how best to deliver that package, whether it is, for example, in a large-scale healthcare system, and things of this nature. And then the fourth session will concentrate on whether or not there are other ways to gain knowledge, either about what would be an effective intervention, or if one's really bold, if we could gain some other form of causal evidence from observational studies. And that's basically the process of how this meeting is going to continue. First, looking at the targets and their engagement. Secondly, at the outcomes. Third, about specific features of the design. And fourth, how to improve what we can obtain from observational studies and even perhaps support some causal hypotheses. But we can't really do this work without the cooperation of a large number of volunteers. And so I'd like to actually call out here to the National Strategy for Recruitment and Participation in Alzheimer's and Related Dementias Clinical Research. This is an NIA plan that we actually formulated with collaboration from the Alzheimer's Association and many other stakeholders. And as we move forward, it's been very clear that the number and the variety of participants we'll be needing in these future prevention trials isn't quite, in fact, quite large, and we'll be really working our utmost to enroll them in our studies, and therefore also to honor and to serve them with their cooperation and their participation in our ongoing clinical research. And that's the end of my talk. And kind of interestingly, we actually are very, very insistent on having breaks and giving people enough time to decompress between sessions. And so we actually will, in fact, start essentially this with a break, and we'll return at 1:30 p.m. for the first session. Thank you.
Great. Welcome back, everyone. I hope you enjoyed the break after the exhausting intros. We're ready to start panel 1, which is going to talk about assessing target engagement. What are the biomarkers that could be feasible and useful in the context of evaluating non-pharmacologic approaches for early prevention? And of course, the biomarkers pose some special challenges with early prevention. We're going to be led off by Dr. Beth Mormino, who's chairing this panel. She's an assistant professor at Stanford Neurology, Dr. Adam Brickman, who will talk about fluid biomarkers, and from Columbia, and Dr. Marty Swensky, who is going to talk about psychological biomarkers that can be used potentially to help identify subtle changes. And with that, I will hand it off to Dr. Mormino. Thank you so much.
Thanks, Maria. Okay, next slide, please. So Jonathan already kind of gave a introduction, but I do want to spend a few minutes just kind of stressing the prevention framework, and especially the time course associated with what we're talking about at this workshop, which is essentially intervening, very early to stop something that happens late in life. And then I'm going to get into kind of more specific details related to how different imaging markers can be used in the context of interventions earlier in the lifespan. Next, please. And there's, I think, a couple overarching questions that we've been thinking about that I think are going to show up consistently through this session and throughout the workshops. So I think one thing we're interested in from the kind of the early detection, biomarker quantification of early change is just whether or not these different measurements of both risk and early disease processes, can they be used in prevention trials that actually do begin very early, like in middle age? So we're going to be hearing about in this session both imaging from me and more of the biofluid work from Adam. And then Marty's going to also present work looking at these everyday measurements of cognition and other processes. And I think we just want to kind of keep in our minds, what is the evidence that we can use these sorts of tools? And even if we can use them, what is actually needed to convince ourselves that having this information will be useful to understand these interventions. Next slide. So I think, especially for the context of very early intervention in middle age, I think it is helpful to think about prevention as falling into two kind of broad categories, primary prevention and secondary prevention. So I think this is helpful, especially for thinking about late life cognitive decline and dementia, because we know already that there are multiple mediating pathways that can lead to clinical symptoms. And we also, know that we can measure, or we hope to be able to measure many of these processes. And these measurements have been shown to emerge well before clinical symptoms. So, there is really an opportunity to kind of leverage these sorts of tools to pursue these different opportunities for prevention. And so in the context of secondary prevention, that would be, we target individuals who are showing some sort of quantitative evidence of one or multiple pathways, but before clinical symptoms have emerged. And in that context, we would try to treat these people and prevent clinical symptoms. So that is what secondary prevention would be. Primary prevention would be, even targeting people earlier. So before there's any sort of quantitative measurement that indicates an early disease process. And there we're really trying to actually, prevent the early changes from happening in the first place. And I think when I think of middle age, I do tend to think that a lot of these designs would be more in the primary prevention stage rather than secondary. But it could be a mix of both. And there certainly is, we know that we can detect early changes, even in middle age. So maybe in that context, it would be considered secondary prevention. But importantly, both of these stages are happening, years and likely decades before clinical symptoms. So that in itself actually highlights one of the issues and huge barriers we have with this problem. If these events are spread out over decades, it really is complicated how we would actually design a study to get at this concept. Next slide. So this is really, the most obvious utility for these kind of early biomarker quantitative measurements. So, in the most straightforward way, we would want to leverage these to just shorten the length of the trial. So we would want to use these measurements, and we would believe that these measurements would eventually lead to some clinical decline. In that sense, we consider them to be a surrogate endpoint. So we believe that if we can prevent this biomarker abnormality from emerging or getting worse, that we would ultimately prevent this late life decline that we're trying to stop. Next. Another use of biomarkers in these early measures would be to specifically target a certain process. So we might have an intervention that we hypothesize to be important for vascular pathways. So then we can design the trial such that we're collecting these sorts of markers that are sensitive to vascular pathways. That might help that trial in terms of having it be shorter, but also to understand whether or not the intervention itself is targeting the hypothesized pathway. Next. And then oftentimes with some of these interventions, especially lifestyle interventions, we don't quite understand what the actual pathways are. So biomarkers, in a sense, can provide a great amount of insight into, how, if there is an effect of a certain intervention, what pathways is it actually working through? And in many cases, it might be a collection of multiple different pathways that we might be able to tease apart with these quantitative measurements. Next. And then, of course, I'm going to talk about a couple examples of measurements. We're going to hear about different measurements that change early throughout the course of these first few talks. But, the hope is that, there's even earlier biomarkers that we don't yet have and that we can develop as a field that would move our ability to detect change even earlier than what we can do now with some of these pathological and age-related processes. Next. Okay, next slide. So I just want to, kind of considering this broad framework of primary versus secondary prevention, I'm just going to go over a couple examples. So right now, there's actually a few trials going on in the Alzheimer's disease space, specifically targeting amyloid. And this sort of framework, is really easy to map on to this sort of approach. So in the AD space with respect to amyloid, we do consider amyloid to be this early initiating event that's important for the disease. And I'm going to have a number of slides kind of detailing the early signal there. But in terms of prevention, you can think of targeting amyloid in these two different stages. So in primary prevention, we would target individuals before abnormal amyloid is present and try to prevent the emergence of that amyloid. So that would be primary prevention. And then in secondary prevention, we tend to think of that as targeting people who are amyloid positive. So typically normal older individuals that have no symptoms of dementia whatsoever, but do have this abnormal amyloid scan. And in fact, there are a number of prevention trials that are taking that approach, both identifying individuals that are normal, but have little evidence of abnormal amyloid. So the AHEAD 3, 4, 5 study is one example. And then also there are studies that are specifically targeting amyloid positive normal controlled individuals with the idea of preventing the future cognitive decline that might happen in that group. And that's the A4 study, for instance. Next slide. And then also Jonathan mentioned the Sprint Mind study. So here's a different study that is also in a prevention kind of framework. And here the target was blood pressure. And the idea was if you can intervene on blood pressure before there's any sort of overt clinical impairment, you may be able to prevent that downstream effect. So here's just it's a different study targeting a different pathway, but kind of shows how this approach lines up nicely on these primary and secondary prevention timescales. Next slide. Okay, so I'm going to switch gears now and talk a little bit about specific imaging changes that we might expect, or how we might think of these imaging changes in the context of middle age. Next slide. So yeah, I'm going to focus, I am going to spend a fair amount of time on amyloid and tau PETs. Next slide. So as I've mentioned, and I think we all know, amyloid positivity is something that does begin well before any clinical symptoms of dementia are present. And it's actually quite common after age 60. So the plot on the left is showing some curves of the prevalence of amyloid positive individuals as a function of age. The orange line is MCI, so we can ignore that for now because we're focused on this prevention concept, and focus on the other two lines, which are essentially normal older individuals. And as you can see, there's very little evidence for abnormal amyloid before age 60, but then there's this nice linear increase such that about 30% of 70-year-olds tend to have these pretty robust amyloid positive scans. And this group has been very, very much of interest in terms of prevention, but this doesn't really start to emerge until after age 60 or so. And then the plot on the right is actually just showing individual data points, again, highlighting that we really have a very flat line. So the y-axis is just a quantitative measure of this amyloid scan. There really is very little signal early on relative to what happens after age 60, where we really start to see these points kind of pop up that indicate this abnormal amyloid process. Next slide. And so this group has been pursued in terms of prevention, but even in this older group that has this abnormal biomarker with amyloid PET, it takes a long time to measure clinically meaningful change. So which is one of the problems that we're definitely going to be facing with the middle age target. So on the left, this is just showing a composite of episodic memory. And the red group is the amyloid positive normal control group. The black is the amyloid negative group. And as you can see, there definitely is a group difference with the amyloid positives declining. But the decline, it's quite subtle. These are Z-score changes. So even after 5 years, this is just, not even getting to 1.5 standard deviations below baseline. And it does take a number of years to get to that far. So this is a huge problem with current prevention trials on just the time that you need to follow these folks. And this is already starting at age 60. So the problem will be, even worse if we start at middle age. And then the plot on the right is just is emphasizing this further, that even when you look at something like CDR, it isn't until about 8 years or so after baseline that the vast majority of amyloid positives will show some movement on CDR. And this isn't even to dementia. This is just going from a 0 to 0.5. So again, it takes a long time, a long follow-up, even when you start an older age, to identify change in this group. Next slide. And then here, so Marty's going to talk more about this in his talk, but this is, I think, a really exciting study that's really leveraging repeated measures. So here, as I mentioned, this decline in memory, it takes a while to emerge from baseline. And so this plot on the right here is work from Kate Papp at Harvard, who has essentially exploited practice effects and has shown that if you show the same face, same pair, if you repeat that once a month over the course of within a year, you can actually see that the amyloid negatives will have this practice effect, though they'll be able to remember this associative memory pair, and they'll improve over time, whereas the amyloid positives kind of lose that effect. So even though we oftentimes think of practice effects as a complication, it actually, in some senses, might be a sign of early disease and might be leveraged to actually help us shorten trial lengths. Next slide. Okay, so I'm going to talk a little bit about the imaging side. So amyloid and both tau PET, we oftentimes do reduce these modalities down to these dichotomous levels. And we tend to think of people as going from amyloid negative to amyloid positive. That's shown in the first row of these PET scans. And then once individuals become amyloid positive, they tend to at first be tau negative. That's shown in the middle scan on the bottom row, before we start seeing tau accumulate in the medial temporal lobe and then spreading. So we do tend to have this tendency to reduce this down to a couple dimensions, based on these scans. Next slide. Next, please. But that is definitely a simplification. So there is this concept of subthreshold amyloid, and it is becoming, the literature is really highlighting that there is more to these scans above and beyond just the dichotomous levels. So this is a little bit of a busy slide, but in the center, I'm showing the Centiloid scale, which is in the field kind of used to be able to quickly compare amyloid values across studies. We tend to think of 100 as being a typical AD dementia level of amyloid, and then 0 being the typical young 20-year-old level of amyloid where we expect no pathology. And when we think of the positive and negative dichotomy, which we can clearly see visually, that ends up being about a Centiloid value of 40 or 30, I would say, where it's very obvious that the scan is positive. However, there's a number of papers that I've listed on the right that have showed below this overt threshold for positivity, these subtle subthreshold values are actually predictive of important things. So for instance, a level of 24 has been shown to actually correspond with postmortem levels of plaque. And then levels of 15 have been shown to predict future amyloid accumulation. A level of 12 has been reported to relate to CSF measures of amyloid, which are thought to occur earlier than PET. So we have now many reasons to believe that this kind of sub-threshold level, so the levels before you become overtly positive, could be meaningful. Next slide. So when we look at PET, so there are not a lot of studies that have looked at amyloid PET across the lifespan. But here's the Dallas study has done an excellent job with this. So on the y-axis are these amyloid values, and then age is on the x-axis. And you can see similar to the plot I showed earlier, where there is this kind of black cluster of amyloid negatives that tend to be quite low. And then we have these breakaway points at older ages, and those would be your typical amyloid positive scans. So one question though, given that we think these subthreshold levels are meaningful, is does it actually track with anything important? And that's in fact what they've shown. So they've kind of honed in on the right on the young adults, and in fact have actually found that even though the range of values is much less than the full range from negative to positive, it actually does relate to memory in their cohort. So this is giving some evidence that even these subtle fluctuations below the overt positive range might actually be an important indicator that we might be able to exploit. Next slide. And then another way of thinking of early amyloid changes could be with respect to change over time. So Here's a few studies looking again at amyloid on the y-axis, amyloid PET, and then here's age on the x-axis. This is an older study from Berkeley. But importantly, all these trajectories are all from individuals that started in the amyloid negative range. So it's showing that if you're amyloid negative, what happens to your PET scan over time? And as you can see, there is this clear cluster, these black lines of folks that are accumulating. So even though they're amyloid negative, it does seem that there's a subset of individuals that will show accumulation over time and kind of jump up above the cluster. So that, could be another target to, start off low and then prevent this accumulation over time. And we've also looked at, what are the predictors of this? So if you are to focus in on the amyloid negative group, what sort of factors predict future accumulation, even in this minimal range? And we do tend to find like this straightforward things like age and ApoE4 status, even in this lower range, are significant predictors of those fluctuations. Next slide. And then, so just like with amyloid, it's probably more complex than just positive and negative. We can ask the same questions with tau PET. So the plot all the way to the right here is showing intrarenal tau, the PET signal on the y-axis, and again, age on the x-axis. This is data from Mayo. And again, we see a similar pattern overall to the amyloid data, where such that there's kind of this flat line at the bottom, a flat cluster, and then we start to see some of these red dots breaking away from the bivariate relationship. Those red dots are all the amyloid positive folks. So we kind of have this coupling between amyloid positivity and overt tau positivity. But a question we have is in this orange box right here, is that, slight fluctuation in tau PET, especially in the stages before amyloid positivity, is this an important signal that we should be thinking about? And especially in the context of the postmortem literature. So we know from the tau PET, or from the postmortem literature on neurofibrillary tangles, that we do expect tau to begin very focally in the medial temporal lobe and the entorhinal cortex. And importantly, we think that this signal is really going to take off between age 30 and 60 or so, which is shown in the orange arrow in the middle panel. So it does seem like it is a reasonable target to think of when we want to think of these very early pathological changes in middle age. Next slide.
I think you have a couple minutes, but you also put your introduction to your slides, so you have a few more than that. But thanks.
Okay, great, thanks. Yeah, I think I just have a couple more. And then just to highlight this point further, groups have started to look at this and have identified, there is some evidence that this early focal signal in entorhinal may be relevant here. This is work from the BioFinder study showing associations with structure in the medial temporal lobe. And then here's work from Keith Johnson showing really nicely that you can perhaps extract this tau signal right around the rhinal sulcus and show some nice relationships with age across starting at between age 20 and 80 on the right, the lower right there. Next slide. And then this is, I'm going to go a little faster for the next few slides. And this is just highlighting that this entorhinal tau signal, does actually, even within the amyloid negatives, it does relate to memory performance in the Mayo study. So highlighting that this signal, could be relevant. Next slide. And then, so just to switch gears away from amyloid and tau, so that, that is one, target that I do think makes sense to consider, but we also know that there's, other pathways that we can capture with imaging that could be relevant to look at as well in middle age. So one example is white matter damage. Here I'm showing a plot on the bottom of white matter hyperintensities across the lifespan. And here I just want to highlight that the relationship with age is very different than what we see with amyloid. So amyloid, as I mentioned, we have a very restricted range and then it starts to fan out. With white matter hyperintensities, we see much more of a continuum, again, stressing the potential importance of these sorts of measures in middle age. Next slide. There's also a lot of excitement. I think this sort of target, looking at the blood-brain barrier, would be quite exciting in middle age. So here's just some recent work on this space, really highlighting that this sort of K-trans measure tapping into blood-brain barrier integrity is disrupted in the context of early disease amongst CDR.5s and is actually completely uncoupled from the amyloid process. So this is, gives a nice, potentially independent pathway to pursue. Next slide. And then, so we're going to hear more about this from Adam, but I do think, like in addition to the potential imaging tools we have, one forward-looking, I think, piece of excitement is really with these proteomic approaches, where we can potentially tap into additional pathways such as metabolism that are, likely very important that could complement some of this work in the imaging space and actually add a lot more power. Next slide. So I think I have 2 slides left. So here is just, I guess this is more of a suggestion or an idea about, how a strategy could work that's focused in on midlife. And I know there's different flavors of this that are already happening with different styles of registries for clinical trials, but I do think the advancements that we've seen recently, both with digital data collection and also with plasma, it does seem like a national registry that started quite early could be quite powerful at this stage. And such a registry, I think, could really feed, both the data science projects that would be necessary to understand how to analyze such complex kind of high frequency data, as well as the plasma data, which is very multidimensional. There also would be a lot of work that it could fuel regarding the assay developments themselves. So one exciting thing about plasma is it could be collected and stored for later. So I think that would, open up future research. And then from the registry, we can imagine these intervention sub-studies where we would be able to recruit from the registry and also leverage all this run-in data. And then that's where I would see that imaging coming into place to both validate this run-in data and also to pursue kind of study specific targets. Next slide. So I think, and then I guess one comment on the transition from imaging to plasma. So we're going to hear more about this from Adam, but it is this obvious solution that's needed if the numbers are quite large. It's obviously easier to collect, it's inexpensive, and importantly, it can tap into more biological pathways than I think we're capable with imaging. However, it is really unclear. The early detection piece of plasma markers is very unclear, and that, especially in this context of middle age intervention, is really important. And also there is a lack of spatial information, which may be more important for some imaging modalities like tau PET, for instance, that we would be losing on the plasma side that are probably very important for early approaches. Next. And then, so just to conclude, so I do think these quantitative approaches, will, have the potential to address a major challenge of midlife intervention, both by studying the study length and also providing the mechanisms of how an intervention might be working. I do think there is this obvious issue of linking the biomarker effects to something that's clinically meaningful, and that problem will be very large if we go earlier, like in middle age. So I think there does need to be a lot of development on the sensitive measurement side of change. I think even amyloid and tau imaging might be helpful in middle age, especially in the context of kind of sub-threshold values. There also are, I think, are opportunities for both subject selection and surrogate endpoints for vascular and blood-brain barrier changes. I do think there's a need for the development of biofluid assays, which can be very important for these sorts of efforts. But I also think the field, we're very much at this kind of key opportunity point, given the amount of tools we have regarding non-invasive data collection in humans. So I think there is a lot of potential paths forward with registries to help with the designs of these trials. Okay, I can end there. I think I took all the time, unfortunately, but I'm happy to take.
Thank you very much, Beth. No, we did give you 5 minutes at the beginning to sort of set up and frame the session, which you actually did do. So I think we're fine. It's a chair prerogative thing. And but now we can introduce our next speaker.
Okay, so next we have Adam Brickman from Columbia, who will be talking to us about blood-based biomarkers, opportunities for early prevention trials of AD and related disorders.
Thanks, Beth, and thanks to the organizers for inviting me to talk about this. So as Beth mentioned, I'm going to be focusing on blood-based biomarkers, which I think is really an exciting area of biomarker research with respect to ADRD. So next slide, please. So these are my disclosures. Next slide. So today I'm going to try to power through 4 general themes about blood-based biomarkers. I'll talk about why we might use blood-based biomarkers in early preventative trials, and this overlaps a little bit with what Beth was talking about, how we might use them, which ones we might contemplate using, and what kind of work needs to happen still before I would say the field is poised to implement blood-based biomarkers fully in these types of trials. So next slide. So why would we use blood-based biomarkers in non-pharmacological strategies to prevent AD or ADRD? Next slide. And Beth covered this a little bit already. So let's remember how we use biomarkers in general. So biomarkers can be used to detect the presence of a disease, to stage a disease or condition, to predict a treatment response, to test drug efficacy, monitor compliance, and monitor progression. In the context of midlife trials, I think that the ones that focus on prevention or early treatment, I think that biomarkers are particularly potentially useful, or blood-based biomarkers, to determine if participants meet some inclusion criterion, to test effect modification or the interaction of a treatment response with some baseline condition or state, and to assess target engagement of the particular intervention. As Beth mentioned, we can also start thinking about using blood-based biomarkers as a surrogate endpoint or an efficacy measure, and we'll get into that a little bit more. So next slide. Of course, the field of AD research has been revolutionized by the development of the neuroimaging biomarkers and the CSF-based biomarker approaches that we've been using for several years right now, and these have been generally focused on the hypothesized amyloid tau and neurodegenerative cascade that defines AD. And these are just some examples of some of the biomarkers we derive from on the imaging side and the CSF side. So next slide. But despite the accuracy of a lot of these imaging biomarkers and the CSF biomarkers for AD, there are a lot of limitations, of course. So first, institutions and in some cases entire countries don't have access to the radiopharmaceuticals that we need for PET ligand imaging. They're expensive. Patients or research participants are often resistant to the procedures or worried about the risks. There may be contraindications. And these issues lead to selection bias in research studies, to limited ability to deploy biomarkers in large trials that would likely be required for primary or secondary prevention studies in middle age. And they might have limited access in clinical settings. I definitely think and agree with Beth as she mentioned that there's a role for imaging and probably CSF biomarkers, but in terms of large scale deployment, it's probably limited to more validation or confirmation type sub-studies. Next slide, please. So I think ushered in primarily by advances in ultrasensitive assay techniques, there's really been an incredible development of blood-based biomarkers for AD. And these efforts have generally focused to date on diagnostic accuracy of AD in well-characterized cohorts that are of older age, 65 and older. And so this is just a sampling of some of the recent papers the last couple of years that have tested the validity and the reliability of some of these assays, primarily for diagnostic purposes. Next slide. So these are, I just thought I'd throw this up here. These are some of the most common platforms that are used to develop and derive blood-based biomarkers in AD, ADRD. And generally speaking, they're either immunoassay-based or spectroscopy-based. Next slide. So there are obviously potential advantages to blood-based biomarkers for AD, ADRD. So blood draws, I think, are considered routine by most older adults or most adults. The barriers related to discomfort or distrust are reduced. There's no specialized equipment necessary for the blood draws, really, although I think we still need specialized analytic platforms to analyze the data. And these advantages lead to less bias in research, greater overall access, and also blood-based biomarkers would be more easily deployed in large primary and secondary trials. They may be more sensitive than the clinical readouts to pathophysiological changes prior to the onset of frank symptoms, and they could potentially be used to test hypotheses about biological mechanisms. So next slide, please. So how might we use blood-based biomarkers for early prevention trials? Next slide. So first, blood-based biomarkers could be used for trial inclusion to identify participants who are at a high risk of decline or who have evidence of pathophysiological processes that are specifically targeted by the intervention. So in this recent study, for example, combinations of blood-based plasma markers for tau and neurodegeneration had prognostic information for who is at greater risk for decline over a 4-year period. So plasma biomarkers could potentially identify individuals with evidence of, in this case, AD or some pathophysiology related to AD targeted by an intervention, or for other factors that are hypothesized to interact or modify the intervention. Next slide. But are we there yet for a big, prevention trial in middle age? I think there's certainly accumulating evidence in older age groups or even in late middle age, but we really don't yet, I would say, have prognostic data or enough prognostic data in middle age, and we don't know enough about how biomarkers work in diverse community-based samples. This depends a little bit, I would say, on what the specific biomarker that one would be considering to integrate into a prevention trial. I'm talking about here mostly the amyloid, tau, and neurodegenerative plasma-based biomarkers related to AD. Next slide. So biomarkers could also be used to determine target engagement. And so our group has been conducting lifestyle and dietary interventions, for example, in late middle age or early adulthood. And in one study, we had an exercise condition and used VO2 max as a biomarker. Granted, it wasn't a blood-based biomarker, but I think it makes the point. And we were using it to determine target engagement. So we found that despite an intensive exercise intervention, there was no change in aerobic capacity indexed by VO2 max, our biomarker, in the treatment group. So we deemed the treatment arm a failure. So on the other hand, in a flavanol diet intervention, we used the blood-based marker VLM, which is a flavanol metabolite, to show that it increased with higher doses of intervention and decreased with intervention taper. So we concluded there that there was indeed evidence of target engagement. We didn't use the biomarker information to determine efficacy. We just used it to determine whether our intervention was actually hitting the target we were trying to hit. And I think these are good illustrations of how we might think about using the blood-based biomarkers in prevention trials. Next slide, please. So can blood-based biomarkers be used to test target engagement? And I think it depends somewhat on the target, but I think generally, yes. I think we can be optimistic that there's emerging evidence that this is indeed viable in middle age, again, depending on the target that we're talking about. Next slide. How about blood-based biomarkers as a surrogate endpoint or to test efficacy of an intervention? I think it's still important to keep in mind some of the guidelines that FDA has put out with respect to biomarkers as efficacy measures in general in AD trials. And they say that in cases of pharmacological intervention, at least, that biomarkers could be used for the basis of accelerated approval if the biomarker effects are reasonably likely to predict a clinical benefit. And I think the same guiding principle is applicable in midlife prevention studies. We might have a hypothesis about what the mechanism is. We might see movement in that biomarker that reflects that mechanism, but that doesn't necessarily mean that the intervention works to prevent cognitive decline or incident dementia. So there really should be reasonable evidence that movement on a biomarker outcome would result in some clinical benefit. Next slide. And I think obviously we can turn to AD trials as an illustration of this concept or the importance of it. Next slide. So in the bapineuzumab trial, for example, there was a lot of movement on amyloid biomarkers, as seen on the left part of the slide, showing target engagement, but it didn't show efficacy because there was no apparent clinical benefit on cognitive outcomes. So this is an example of how biomarkers would be appropriate perhaps to show, target engagement of some sort of a mechanism, but wouldn't really capture the efficacy of that intervention because its reduction didn't result in a clinically relevant cognitive outcome. Next slide. And indeed, across amyloid trials, there's a lot to learn from them. In AD, there's been consistent evidence of amyloid reduction overall without meaningful impact on relevant clinical outcomes. And this is a lesson that we need to take with us when we're thinking about the prevention trials early in life. We can be very seduced by exciting biology and exciting ways to measure all sorts of things in the blood or in fluid, but we should be a little bit cautious about how meaningful that is. So next slide, please. So are we ready to use biomarkers as a surrogate endpoint or efficacy measure in midlife prevention? And I would say that there's really currently insufficient evidence that changes in biomarkers are more sensitive than changes in cognition. if we can measure cognition very well, as we'll hear from Marty, or that it predicts meaningful clinical outcomes. But I do think it's important to start collecting the fluid and to start understanding in parallel with cognitive endpoints to start testing these possibilities. Next slide. So which blood-based biomarkers should we be using in these hypothetical midlife and prevention studies? Next slide. Obviously, the science or the question should drive the selection of biomarker and should be considered, and we should consider putative mechanism of the intervention, the purpose of incorporating biomarkers we've discussed, and its prognostic utility. Next slide. There are obviously a lot of targeted fluid biomarkers that have been identified and developed that may be more specific to AD than other factors, reflecting amyloid tau and inflammatory and synaptic dysfunction, for example. Next slide. And efforts coming from large consortia like the MARC VCID study are developing targeted fluid biomarkers that are relevant for factors that may be particularly important in midlife, like those that are associated with vascular cognitive impairment, as Beth mentioned. Next slide. And then, of course, there's a whole world of untargeted omics types analyses, such as these led by Higginbottom and Walker in the AMP-AD and the ERIC studies, that are identifying potential fluid biomarkers that can inform either treatment targets or prevention strategies, or be leveraged to use as single biomarkers or combinations of biomarkers that track with risk for disease state or future cognitive impairment. So next slide. So what needs to happen before we can fully implement blood-based biomarkers into prevention studies? Next slide. This is a slide that I stole from Maria that I think is particularly relevant here. So, of course, different study designs are best suited for different scientific goals. So to test causality, for example, we need experimental designs. To maximize statistical power and measurement quality, we rely on volunteer cohorts and clinic-based cohorts. And to date, the implementation and the development and the testing of blood-based biomarkers have generally and probably appropriately been restricted to these types of designs. However, to test the generalizability and applicability across diverse populations, the strongest designs are ones that really incorporate population representative cohorts. Next slide. So moving forward, we clearly need to test blood-based biomarkers in population representative midlife cohorts. We need to understand how the biomarkers operate across different groups of people, and we need to know the natural history of biomarker levels in order to power clinical trials appropriately. Next slide. So we recently completed a small blood-based biomarker study in YCAP, which is a community-based study of aging and dementia that includes diverse racial and ethnic groups that represent the population of Upper Manhattan in New York. Next slide. And we found that plasma-based AD biomarkers were generally associated with both neuropathological, shown here, diagnosis of AD, and also clinical diagnosis of AD, particularly those markers that reflect phosphorylated tau. And these associations in our initial analysis didn't differ between race and ethnic groups. The associations were not as strong as those that were reported in more clinic-based or homogeneous samples, like those from the BioFinder study, but we still see reliable associations. Next slide. When we look at correlations with age, the associations, again, were most reliable for p-tau measures, and here NFL, neurofilament light chain. Even though these are all older adults, there was a fair bit of variability at the lower end of the age group, suggesting that these markers might be able to detect relevant information in midlife, or at least in pre-symptomatic stages of the disease. Jennifer Manley and I direct a study called the Offspring Study that examines the adult middle-aged children of the participants in this YCAP study, and we've begun measuring systematically blood-based biomarkers related to Alzheimer's disease and vascular health, which might prove to be quite relevant in planning preventive studies. Next slide. But in true midlife studies are still pretty rare. And so this is an interesting study that incorporated AD-related plasma markers in middle age. And the authors showed that the plasma markers of beta amyloid and total tau differed between midlife participants with and without cognitive impairment, showing that there might be enough sensitivity, at least early in midlife, and these were about age 54, I think. So there's certainly evidence emerging that these biomarkers have utility earlier on. Next slide, please. So in conclusion, I'd say the blood-based biomarkers could be included in early intervention or prevention trials for inclusion, to assess target engagement, and potentially for efficacy. The selection of biomarkers should be driven by the science, by the question, by the hypothesis of mechanism. And early evidence does suggest that many blood-based biomarkers work well in older clinical samples, but we need more observational data from midlife cohorts that are population representative. Next slide. So I'd just like to thank some of my collaborators on the biomarker work from Columbia and from Eli Lilly, and for NIA for funding much of this work. Next slide. Thank you very much for your time.
Well, this is wonderful. You actually finished early. And if there's a real quick clarification question while Marty's setting his slides up, maybe this is an opportunity here.
I could ask a question. Oh, no current, I see in the chat. So there's no questions from the chat. I was wondering, Adam, if you could talk a little bit about the, like the offspring study seems so critical for these questions. And you did mention you guys are measuring, AD markers, but yeah, I mean, can you talk about kind of the non-AD kind of targets you're gonna?
Yeah, I mean, I think that you sort of hit the nail on the head where before when you said we should be collecting and storing plasma because the markers emerge and become available as we develop them. I think right now we're focusing on amyloid tau, phosphorylated tau, neurofilament light chain. We're also getting measures of cholesterol and markers that might reflect pre-diabetes or diabetes. And the plan is to really bank the data and to maybe implement some of these markers from the MARC VCID initiative that are looking at markers of angiogenesis and vascular health in general. So I think that particularly in midlife, particularly in diverse cohorts that are representative, a lot of the potential sources of cognitive impairment or predictors of later cognitive impairment are probably centered around vascular disease.
I think there's a couple, yeah, we still have a minute. There's a couple questions in the chat too about the whether or not you guys are noticing differences in racial and ethnic groups in these different biomarkers.
Yeah. So we published a paper that I showed data from in 2021 comparing racial and ethnic groups on all the plasma biomarker levels. And it was a small sub-study. We were just, or we're hopefully about to be funded to test these plasma biomarkers in literally thousands of people longitudinally. So that study only included 300 people. We didn't see systematic main effect differences between race and ethnic groups in the biomarkers that we studied, nor did we see interactions involving race or ethnicity, so that the associations, at least in these preliminary analyses of the AD biomarkers with diagnosis or with pathological features, seem to be pretty consistent across the different race and ethnic groups.
Okay, thanks, Adam. I think we can move on now to Marty's talk. Excellent talk. Okay, next up we have Marty Slawinski from Penn State, telling us about measurable subtle changes in psychological processes, challenges and opportunities.
Hi, thank you, Beth. So today I've been tasked with discussing psychological processes that could index change in the context of an early dementia prevention trial implemented in midlife. My emphasis is going to be on this notion of change because I believe conceptualizing, detecting, and measuring change is going to be absolutely critical to this endeavor. Next slide. I have three goals for today. The first, I'm going to provide a framework for thinking about how to measure change and also say a few words about the size of the effects we'll need to detect. And by way of preview, they're important but very small, I think. Second, I'll describe a few fundamental impediments that I think are very important to think about when we're designing a trial that's intended to target cognitive type outcomes. And then finally, I'll conclude by identifying what I believe are some important next steps in this endeavor and some opportunities. And although I'm going to be mentioning a few candidate targets, my focus is going to be on broader implications for study design and the development and validation of these types of measures. Next slide, please. So this should be a figure that's familiar to all of us, or maybe most of us. Most of my comments are going to pertain to psychological targets that are measured through self-report, things like social isolation, loneliness, depression, stress, and my favorite target, negative repetitive thinking. which I'll describe in a little bit more detail. I'll also be talking about behavioral and performance measures of cognition. Now, this model implies a few things that aren't made explicit. First, it implies the passage of time that moves from the left to the right of the figure, but often isn't explicit about the time scale. And Beth and Adam have pointed out that for dementia prevention trials conducted in midlife, the interval between a preventive intervention and a relevant clinical outcome is likely on the order of decades. Next slide. So this really does present the need to seriously consider the role of surrogate endpoints that could significantly shorten this timeline. Now, I'd also like to point out another change that I made to this figure. I've added delta symbols to both targets and endpoints to make explicit that measuring change is fundamental to establishing both target engagement and target validity. So to show an intervention changes the target means it's engaged, but also to show that changes in the target are related to changes in some sort of endpoint or outcome is important for establishing its validity. And this is important for two reasons, at least two reasons. First, we shouldn't assume that the time course over which we'd observe changes in targets would be the same time course over which we'd observe changes in endpoints, even surrogate endpoints. So this just has implications when we're designing assessment protocols. We may need to have different timescales over which we repeat assessments. The second reason this is important is that emphasizing change provides longitudinal evidence support, or actually the longitudinal evidence supporting the existence of modifiable risk factors such as loneliness or stress or negative repetitive thinking is only quasi-longitudinal because it typically involves relating status on these variables, which are measured at a single time point, usually a cross-section at baseline, and then relating those static individual differences to subsequent cognitive change or maybe incident clinical outcomes. There's actually relatively little data to support the notion that changes in these candidate targets are associated with changes in cognitive function, and I'll illustrate why that's important a little bit later. Next slide, please. So the lack of demonstrating these types of change effects is forgivable because these effects are very hard to detect. A study by Lipnicki and colleagues involved 14 cohorts with follow-ups between 2 and 14 years, and essentially they found that rates of cognitive decline was on the order of 0.01 to 0.03 standard deviation units per year, which corresponds to during a typical NIH grant period, a cumulative change of less than 0.1 standard deviation units. When we look at change associated with disease progression, it's larger, but not much larger. Publications from the Einstein aging study have found that annual rates of change in the 5 years immediately preceding dementia diagnosis is about 0.14 standard deviation units per year. And again, that's much later in the disease course than a midlife prevention trial would target. So this is important. These effect sizes are important because they might place upper bounds on potential intervention effects that are implemented. And these upper bounds would even be more stringent in midlife where we expect the change to be even smaller and more subtle. So the point here is that measurement error and the influence of unmeasured variables could easily overwhelm the type of subtle signals we're trying to detect. Next slide. So in the context of clinical trials, we sometimes just think of change as an outcome. So we look at change relative from sort of a pre-intervention time point to change at a post-intervention time point or maybe a few post-intervention time point. But in real life, change is an ongoing process that unfolds over multiple timescales ranging from moments in the day to decades over the course of one's life. So even though for this purpose, we're really interested in longer term change driven by the progression of disease processes, that interest doesn't mean we can ignore changes that happen over a faster timescale and that might be driven by other types of influences, such as normative life events like retirement, non-normative events like living through a pandemic, or other kinds of experiences that vary from day to day, such as social activities and work demands. And all of these types of influences can impact both assessments of psychological targets, such as stress and loneliness, as well as cognitive performance. Next slide, please. So when we ignore the influence of especially short-term variability, this can lead to something that we've called temporal sampling error, which is one of the two important challenges to measuring subtle change that I'll describe. So what we mean by this is that if we were to measure an individual only once at baseline and then again once at a follow-up occasion, it's possible for short-term variability to do two things. One, to reduce measurement precision if we happen to get an individual on a particularly bad day or good day. And the second, it could potentially obscure long-term change if the effects of short-term variability are large relative to the kinds of declines we might expect. Next slide. So to illustrate the potential impact of this type of issue, I'll just draw on a few studies my colleagues and I have conducted that involve measuring stress and cognitive performance every day or even multiple times per day for a week or two. So we found that systematic effects of stress from one day to the next are roughly equivalent to a 3 to 5 year age difference. So what this means is if we compare something like working memory performance on a high versus low stress day, that difference is equivalent to what we would expect attributable to about 3 to 5 years of aging. So what this means is that there is indeed the likely possibility that fast changing and difficult to control variables such as stress, fatigue, whether you've had a good night's sleep, could overwhelm the types of effects that would be looking for based on interventions designed to alter the course of long-term change. Next slide. So the second important challenge, which has been alluded to by Beth, is that of retest effects in longitudinal studies. And these effects occur even if we're using alternate forms. They happen anytime people have repeated opportunities to do a similar or the same testing procedure. The magnitude of these effects are relatively large and durable. They can persist for periods up to 7 years. And retest effects are important to think about because they can mask the kinds of changes due to disease progression or intervention effects we might be interested in. So the figure on the right depicts this, and it shows the result of how to interpret a situation in which there's no apparent change from baseline to follow-up. The solid black line indicates observed performance that might not change from baseline to follow-up, but that could actually be driven by sort of reflecting a mixture of two latent unmeasured competing processes: retest-related improvements, which might be offset by some sort of cognitive decline. And it's important to try and separate these processes because we might think that a very early sign of potential impairment might be the inability to benefit from repeated exposures to the same testing procedure, the lack of practice effects that Beth talked about. In that case, we'd really want to focus in on measuring the green line. Or an intervention that's designed to delay or slow the progression of some sort of underlying neuropathology might mitigate or slow rates of cognitive decline associated with that, in which case we'd want to focus on the red line. Now, unfortunately, in most longitudinal designs, it's absolutely impossible to distinguish between these different processes, which can potentially mask the effects of interest. And I'll illustrate that in the following example. Next slide. So what I'd do is I'd like to take a moment to describe some recent work on something called the cognitive debt hypothesis. And I'm going to do this not just because it illustrates this methodologic issue that I'm trying to point out, but also because it identifies what I consider to be a particularly promising psychological intervention target. So we know a number of psychological risk factors for cognitive decline have been identified. These include things like depression, anxiety, and stress. So the cognitive debt hypothesis suggests that a common psychological process, repetitive negative thinking, or RNT, underlies all of these variables. And basically what we mean by this is things like worry and rumination. Repetitive negative thinking is a really viable intervention target for two reasons. First, because it's modifiable by interventions such as mindfulness or cognitive behavioral therapy, and also because it's been recently linked to AD-related biomarkers. There's a huge literature on perseverative cognition, repetitive negative thinking from health psychology, showing that it plays a mediating role in depressive episodes, in the effects of chronic stress. This could potentially be a high yield variable to pay attention to. But what I'd like to focus on here is a recent demonstration of differential trajectories of cognitive change among people, older adults who scored high and low on a measure of repetitive negative thinking at baseline. And what you'll see in this figure, and this is a delayed memory test, is that these differences in trajectories emerged only after about 2 to 3 years of follow-up once retest effects have dissipated. So this is important because in some cases, retest effects can expose a difference. In other cases, it can potentially mask a difference as it's done here. So knowing which change process, something like repetitive negative thinking, is impacting the inability to benefit from retest or accelerating cognitive decline seems to be important when we're designing an intervention study. Next slide, please. So to some extent, the situation we have, our task is kind of like looking for a needle in a haystack, but fortunately, there's some opportunities that we can draw on to amplify signal and reduce measurement error, reduce noise to make this task a little bit more feasible. Next slide. These opportunities, I think, will rely on utilizing higher frequency intensive measurement designs that can play an important role for improving measurement of subtle cognitive changes. And there are numerous ways to implement these types of approaches. Our approach has been to embed very brief cognitive tests into ecological momentary assessment designs, which involve frequent repeated assessments, like maybe multiple times during a day over a period of multiple days. And what we and others have demonstrated is that by averaging over these repeated assessments, we can boost reliability by canceling out short-term variability and get reliabilities of in excess of 0.9. There are other advantages to implementing these types of intensive measurement designs, such as measurement bursts. It allows us to examine change and variability across multiple timescales and opens a door to examining some types of digital biomarkers. Next slide. So in another example of turning lemons into lemonade, Jason Hossenstub published a paper a little while ago, which demonstrated that the absence of retest or practice effects could be prognostic of who converts to cognitive impairment and who doesn't. So this is really interesting, but the problem with these types of designs is when we just have this single trajectory, we can't tell if it's really the absence of practice effects or that there's just more decline going on in the converters that offsets retest effects that remain equivalent. Next, please. So if we implement an intensive measurement design, it becomes possible to apply cognitive processing models that can very precisely tease apart effects of retest and cognitive decline over the long term. These data represent data from a real person, an older adult who's participating in the Einstein aging study. The red dots are data, daily assessments of cognition over about a 2-week period, and the blue dots are the same that occurred about a year later. These curved lines are theoretical, or actually a computational model fits that separate out rates of learning as well as estimations of asymptotic or best performance. And what we see here is that even though people are getting faster, the dependent variable is response time, even though this person is getting faster from the first to the second burst, we can see subtle changes in asymptotic performance. So this could be a way of trying to hone in on and leveraging retest effects. Next slide, please. So other possible uses of intensive measurement designs is to identify different types of digital biomarkers, such as getting a better handle on short-term variability, which there's now ample evidence to suggest that could be part of the signal and have prognostic value. And also, interestingly, it might be possible to leverage micro-longitudinal studies to accelerate target validation. So for example, we could look at how interventions designed to affect social engagement might impact cognitive performance on the following day or the following week to assess target engagement. Next slide, please. So where does that leave us? So I think that there needs to be much more work done on longitudinal validation, which could involve using intensive measurement designs that could conduct psychometric analysis appropriate for modeling change. A lot of the psychometrics validation we do, such as calculating reliability, isn't necessarily relevant for determining how well a particular measure will work longitudinally. So I think there's a lot of work to be done here. And this is going, next please. And this is going to require that we obtain measurements much more frequently. How frequently? There's some guidance on this, which I could talk about in Q&A, but I think one of the important issues is that this is really going to rely on pervasive technology to reduce burden in individuals and also utilize and validate passive data streams, again, to reduce burden, to try and approximate near continuous measurement of the kinds of behaviors we're interested in. So there are tools that are currently being developed that could assist in this regard, and you'll hear more about them in a later session from Richard Gershon when he talks about the mobile toolbox. Next. So I'd like to thank my collaborators and thank you for your time and attention, and the NIH for their funding of this work.
Well, gosh, 3 minutes left. Does anyone have a quick question here? I should point out that when we finish this session, there will be a small break, and then actually the discussion section for this whole first session of 20 minutes. But if anyone has a quick one right here, this would be great.
I wouldn't mind asking a question. Oh, actually, so Nina has posted, can Marty say a few words about group versus individual differences?
Yeah, so, if by that you mean making inferences about individual person-specific change, it's very difficult to do that with the kinds of data we collect. Yeah, so it's very difficult to do that with the kinds of data we typically collect. With some of the intensive measurement designs, a colleague of mine, Zita Oravec, has been applying Bayesian methods to try and identify posterior probabilities as to whether or not a person, an individual, has declined. And I think applying those types of techniques to where we can help kind of improve the ability to identify specific individuals who have a high likelihood of decline is important. But again, we need more data than maybe just 1 or 2 assessments every year or so.
I want to ask a quick question. You mentioned this disconnect between change in target versus change in endpoint. Do you think of that as a study design issue or a statistical modeling issue?
Well, I think both. I mean, I think, right, you need to plan the assessments in accordance with some sort of theory of change, of sort of, over what time course do you expect the target to change? Over what time course do you expect, changes in the target to influence the outcome in a way that you think is meaningful? And then there are, of course, analytic issues when you have repeated measurements that don't occur over the same frequency that you just need to think about how to handle. So it's a little bit of both.
So maybe we should stop. Should we stop there? And then we'll take, there's a couple more questions coming in. Maybe we can start the panel discussion with these questions.
Absolutely. We can start the panel discussion of the questions that are coming in. We get 5 minutes to type their new questions in, and Jess will help you sort through the questions and we can do them right then. Okay.
All right. Thank you, Marty. It's great. Excellent talk.
Okay, we should be coming back now. So Beth, you have the session chair. You maybe can see the questions coming back up at you.
Yes, I think so. Okay, maybe we can do the 2 from Marty since he just finished. Okay, so one question for Marty: how early and at what age do you think we can start to detect decline?
I'm very confident we can detect decline at age 57. That's me. So that's a tricky question, and I don't have a good empirical basis. But I think how I would ask the question: at what age and over what time frame can we detect meaningful change? Because we also have to realize that we shouldn't just be focused on detecting and measuring monotonic decline. To the extent that we think these things are modifiable, people could voluntarily be engaging in behaviors that could be improving their cognitive function. So, I think, I think we can detect meaningful decline over the course of at least a year, and the age. I think it kind of really depends. If it's there, I think it doesn't matter what age it is. That's not a super satisfying answer, but it's the best I can do.
I mean, this kind of comes back to what Adam brought up during his talk, like the link between, if we were to measure something with biomarkers and clinically meaningful change to some degree. I mean, the same could be asked about these measures as well, the link with clinically meaningful change. To me, this seems like a tremendous problem. I don't understand how we would do that in middle age if the clinically meaningful change is dementia, frank dementia at age 80 or even 70, 65 if it's like an earlier presenting case.
So an interesting feature here is that it may not be clinically significant, but there's some functionally significant cognitive change you can start measuring actually in people's 20s.
Yeah.
So Tim Salthouse really in the Virginia Cognitive Aging Project was measuring changes in reaction time and computer processing speed. And you're never as good as you were when you were 22 or 23. And we can sort of understand that that's probably not that far from the case, because basically your championship video gamers do not have careers in their 30s. Yeah. They're playing different games or they're doing commentary or something. By that point, they're already far enough behind at least the elites to do something. I have no idea whether this feeds into any sort of functional relevant change in terms of dementia outcomes or what have you, but clearly the substrate that we start with starts to show some signs of something like wear and tear pretty early.
Yeah, I mean, there's a follow-up comment on the chat now asking, meaningful decline has been mentioned a few times, but how do we define that? I mean, that seems like that's one of the big questions here.
I wonder if, maybe this is not the right way to think about it, but I think of weight gain, right? So gaining a pound isn't a big deal, but if you gain a pound every year, by the time you get to be my age, right, that adds up. And so I think identifying, what it is we need to monitor. So I'm not sure we need to wait until a person's put on 25 pounds before we say this is important to measure, I don't know whether that's the right analogy.
Okay. Another question that was directed towards you, Marty, I believe is, can you comment on kind of the link with digital biomarkers and education as well as stress and anxiety? I mean, you kind of talked specifically about stress at the beginning of your talk, but.
Yeah, well, so that first piece about level of education, and I think I don't think it's going to be a huge deal in middle-aged and younger folks. I think where we really began to sort of see education affect digital uptake, and there could be others on the panel who know or in the attendees who know way more about this than I do. It's in older ages, and I think that gap is smaller at younger ages. But to the extent that we are going to rely on digital tools, it just might be important to always think about, we budget to provide people with smartphones if they don't have the right kind. So if you don't do that, you can create some, biases, especially if, access to data plans and such. If sort of stress and anxiety is not sort of in the way we think about it as psychologists, but sort of reactivity to assessment, what's more stressful, doing something on a smartphone or in front of a person with a white coat who's measuring your memory in the context of a formal neuropsychological assessment? So, I think there are these types of reactivity issues to different kinds of assessments, but I don't think it would be any more than what you see in a conventional sort of clinical assessment, and maybe less.
Okay, here's a question for Adam. Oh, sorry, there's like the chats are coming up as I'm reading them. Okay, so this is another question about the issue of differential sensitivity and specificity of fluid biomarkers by racial and ethnic groups or social factors. Yeah, do you think that this is settled by your YCAP study? I mean, you kind of essentially said.
No, not at all. Thanks for the question, Maria. So the YCAP study that we've published is really just our initial look, and I'm not going to say it was pilot data for a grant, but it might have been. And now we're going to look in a much larger cohort. I think, but it's important that to emphasize that the YCAP study represents the community that we're drawing from, and a lot of other studies that have reported or examined race or ethnicity differences in biomarker concentrations or imaging markers, weren't necessarily designed to ask that question, or if they were, the recruitment strategy may have differed systematically between the different cultural or racial and ethnic groups. And you can't prove it, but you could explain the observed differences through the lens of how the person got into the study. And I think that that's really, really important to enter in the conversation when we talk about race and ethnicity differences, or people who are testing these, to understand, well, how are they recruited, and how do they, not only how do the different participants, how do they compare to each other, but how do they compare to the population from which we're drawing? And are there systematic differences that might explain some of these level differences that are often sometimes reported? So there's a lot more to do, a lot more to do. And my hunch is that Alzheimer's disease is the same disease across all different people. Plaques don't differ between different groups of people, but how the moderators and mediators of the effect of pathology, or the things that might influence pathology, may differ across different groups.
I'm gonna scroll. I'm sorry, this is more difficult.
So I have a question while you're scrolling, and it's sort of for Adam and you, Beth, maybe. Recently at NIA, there's been a lot of interest in looking at phenotypes that may be accelerated by aging per se, rather than, you know, the appearance of frank neuropathology. So since the development of, for example, the methylation clocks, you can actually demonstrate that some individuals, due to life experiences, seem to, or at least the methylation age you can assign to them based on the status of that, often just from blood, is advanced. And so you can sort of think of that as a potential causal or causative factor. Do you know if anyone's working within like the AD prevention trial space, or anything in here looking for those sorts of just acceleration of normal change kinds of phenotypes rather than the appearance of neuropathology?
I don't know those markers in particular. But I will say, I do think this is a very interesting point. I mean, we often throw age in our models as a covariate and just suck up that kind of variance. And then we look at these things on top of it, or maybe we'll look at interactions with age. But it does seem like from the biomarker standpoint, we do have we haven't really addressed age, like real biological age and the variance around that measure. And it oftentimes is explaining the most amount of variance in our models too. So we're honing in on the sliver that, you know, independently hangs with something like amyloid, for instance, above and beyond age. I do think that's, yeah, it's quite important. You know, Adam.
Yeah, I think it's a great question. There's certainly people working on methylation or other biological markers in aging. We have a postdoc in our group, Indira Turney, who's working with Dan, and I'm blanking on Dan's last name.
Belsky?
Yes, Dan Belsky, thank you. To examine some of these questions within the context of a community-based study across different groups. But I'm not aware of anyone who's modeling biological age or in the context of treatment at any point in the lifespan, let alone middle age.
Okay, so we have a question here. This is about target engagement. So multivariate analyses of multiple targets. Yeah, so I think this comment, it's asking, you know, we're kind of talking about these things as one target at a time, and should we expand to kind of a multivariate framework? Yeah, so instead of focusing on one outcome, should we look at multiple outcomes? I think this is a reference to the different maybe biological pathways, but I suppose it could be for any of the outcomes we've discussed. Yeah, so I think absolutely this is something that is needed. You know, in all the postmortem work on dementia, there's no such thing as Alzheimer's disease in isolation. It's always multiple different pathological processes. I think in the imaging space, you know, we have such good, I think such robust measures for amyloid and tau in terms of them showing what we see postmortem and showing, you know, relating to other proxy measures that, you know, we have really focused on those because we can measure them quite reliably in humans. But if you think of like the TDP-43 work from Keith Josephs and Julie Schneider, like they have shown that TDP-43 is very common in Alzheimer's disease. It explains as much of the variance in memory as tangles in older cohorts. And interestingly, it does impact entorhinal cortex and CA1 early on, and that's exactly where we see tangles. I think that story is probably one of older age, of 80-year-olds, maybe doesn't necessarily translate to midlife, but it's a good example that there are various things that we're not easily measuring, that we're not accounting for. So I think we need to, but I think we lack the robust biomarkers to tap into these biological processes. I've been very excited by the AMP-AD work showing these kind of nice like co-expression networks of tapping into different, biological processes that we, hypothesize are very important for dementia risk, and would love to see that work, translated to like the biomarker level to be able to extract that from, living participants and use that in our markers to kind of get at this theme.
Yeah, Beth, maybe I'll add too. I think that there's definitely a role for collecting blood in the context of trials and using some of these omics analyses to identify if there are in fact things that move with the intervention that we didn't hypothesize a priori, and this might be the only time publicly I'll ever say that machine learning is good. But I think that there are probably ways of grinding through metabolomic, proteomic data, for example, to identify clusters of participants who might have a treatment response or who might respond, show a cognitive or behavioral signal that we wouldn't be able to identify if we just pick a single biomarker. There might be some higher order combination of biological changes that need to happen in response to a treatment in order for it to manifest as an improvement in cognition.
Yeah, and I think a point too is like if we target just one pathway, we can only really kind of prevent decline in that fraction of the total kind of cognitive possibilities with change too. So I don't know, it feels like that needs to be worked in somehow with assessing these different targets, that you can't change all of cognitive decline. You can only change whatever your pathway is targeting, which we're not, I mean, clinical trials aren't really doing that.
I'll just comment that, like, there's a lot of psychiatry treatments in psychiatry. It was what works or what serendipitously worked, and then why does it work was the post hoc question, not the, so I think there's a little bit of hubris in our field that we figured out all the biological pathways. And I always joke that it's going to be my nephrologist friend who's going to be trying out some medication, and all of his older patients are going to look cognitively great. But it doesn't work on the kidneys, and then later on we'll be like, well, why does that medication work? I think that I think we have to understand the history or celebrate how important discoveries have been made serendipitously in brain health in the past.
So Beth, one thing you mentioned in your talk that, because you were going really fast, but I think I'd want to hear a little bit more about it, is you're actually proposing would look like a fairly interesting sort of brain or person registry sort of design, where you would actually, have a very large group you're following prospectively from what would seem to be an absurdly early period of time, but maybe not as early as that. Have you sort of written about that anywhere we can read, or is there something else you'd like to say about that here?
I just wrote about it on that slide.
Okay.
I think this is like it's an opportunistic time, I think, for the field. I mean, the plasma developments, even though, there's so much more data that needs to be collected, but the advancements in the technology that Adam covered and our ability to multiplex and extract these, very low concentration proteins has been phenomenal the last couple of years. Whether or not it will translate to anything meaningful for prediction or for targets is something else. But to be able to actually extract these proteins, and it's just so, I mean, there needs to be a system for the storage and the analysis of these things. So that would be the cost, and also the cost and I think the cleverness of how you analyze the data. But in terms of the subject burden piece, that's what we should be doing. We should be developing tools that are minimal for the subjects and hard on us. Now we're kind of doing I think with PET, oftentimes it's a little bit the opposite, and lumbar punctures too. So I think there's like this key opportunity to really invest in plasma over the long term, and for questions related to early interventions, it seems like it would be feasible to do this early on. And then I think in parallel, the digital capture is quite exciting as well. So it seems like there's this coincidence that we have both these kind of behavioral measurements that can be captured but need to be probed, and also these plasma measurements. Yeah, that's I just kind of, I guess, the general idea.
I want to ask you guys something that I consider one of the harder problems here, which is you sort of all alluded to, but I didn't hear a solution. And I'd love it if you have an idea of a solution, which is, I think that we're going to not have that much difficulty finding things that predict subsequent clinical outcomes, but it's going to be very hard to establish that that there's no way to change that surrogate endpoint without improving clinical outcomes. And that really is a criterion that we need to use if we're going to use it as a surrogate endpoint, is to say, if you've changed it, it's convincing evidence that you've done something useful for the person, not just that it's predictive. And that to me seems like a huge challenge because of the delay. And I'd love to know if you have thoughts about that. And maybe the solution is just to say that the surrogate has to depend on the intervention, that you have what would be convincing depends on the intervention, but love to hear thoughts.
You know, I was going to say, I wonder if, you know, John had mentioned the study that was done many years ago where there were some evidence of functional changes. So maybe finding some ways to assess functional changes, maybe finding some way to get an assessment of performance at work. And this is where subjective cognition actually could come into play as well. Something that, to the extent that people feel like they're more mentally intact, could have a positive cascade on important health behaviors. So I think it's an important question. That's not a solution. It's just my initial reactions.
I guess when we think of the meaningful change, this kind of gets back to the meaningful change. Are we thinking that we would want to detect something in midlife that is important to a midlife person, or we're trying to detect something that's an early indicator that some process is going on and that this person eventually is going to get dementia? Those seem like two different things, and like many different pathways would influence both of those.
Well, a previous meeting that we held about whether or how in the world you were going to get people to adhere to a lifestyle intervention to prevent Alzheimer's disease starting in midlife, you had to do something for 10 or 20 years. One of the obvious things is if you could find interventions that also had relevant functional positive outcomes while you were doing them, that you had a much higher chance of possibly making that work. But you're right, I mean, that's a really good question. And in many cases, coming up with the measures that are sufficiently sensitive in midlife, you know, is in fact, as Marty was pointing out, not always the easiest thing to do either for level or change for that matter. But gosh, it's 3 p.m., which is the witching hour. The shift to the next panel. We'll get a chance to come back and do the global discussion again. I think this has been really interesting, and I thank very much the people in panel 1 telling us how to engage targets. Which flips us to panel 2, the panel on measuring outcomes. And Richard, you are the chair, so I will hand it over to you.
Okay, I hate to ask, can you hear me now?
Coming in perfectly.
Perfect, okay. So 3 speakers for our next session are myself, Yakil Kiros, and Lauren Nicholas. And we're going to be talking about integrating the information which we just learned from the first panel, and then how is that practically applied? Are there measures exist or systems that exist that can take this, that can detect the subtle changes in cognition and behaviors that the previous speakers have been talking about? How do we do those things over time? How do we come up with systems that enable some of the data sharing or the data collection that may be necessary? And are there such measures that can detect the fine level of changes, collect the baseline data, and as we go on to ascertain whether there've been changes over time. It's always been a pet peeve of mine that if you take, if we have a IQ based cutoff for dementia, that if someone's got an IQ of 130, do they have to drop 50 or 60 points before we detect that they have something going on with them? So this concept that we need to assess people over time, is really important one, and therefore we have to have measures that do that. I think with that, rather than steal anybody else's thunder, we'll go in a minute or two early, unless Jonathan, you want to add anything, and we'll get Yakil started.
Thank you. Can I get the slides? Perfect. As it was mentioned, so I'm just going to start the discussion by talking about the standard neuropsychology measures and outcome, and discussing some of the challenges and opportunities. And Derek, can I get the timer too, please? Perfect, thank you. As it was mentioned before, so as Alzheimer's disease clinical trials move earlier into asymptomatic stages, so we are now faced with testing of individuals that are not impaired. So individuals now are being selected with no impairment in neuropsych test. And also, as it was mentioned earlier, they are included in clinical trials, mostly based on biomarker evidence, and biomarker evidence that is linked to risk for progressing to Alzheimer's disease, dementia. Also, as I was mentioned earlier, so in midlife, so it is pretty much the criteria for entering the trials. So in this case, and this is something that I'm going to be mentioning during the presentation, but it's very clear that the way that neuropsych testing is conducted, or the way that neuropsych measures has been designed, is not the best way to select individuals, because the neuropsych testing that we have has been actually designed to identify or diagnose individuals based on impairment. So this actually put us in with some challenges based on how to identify the best candidates for these trials. Next. And here I'm pretty much summarizing the big challenges that I think that we are facing, and we have been facing for several decades. The past decade actually, and we still continue to face. The first thing is that the traditional and the standard neuropsych tests, or the cognitive tests that we use, including some of the questionnaires that we are using, they may be not optimal for preclinical and prevention trials. And the main challenge that we have, the first one that I put here, is that we actually need to be able to detect, and as it was discussed before, some of these subtle cognitive changes in individuals that are normal and are clinically normal, and they actually normal by the neuropsych, the standard neuropsych testing that we have. And this is something that in my group in particular, we have been doing for the past years in young individuals, mostly those that are at genetic risk by autosomal dominant Alzheimer's disease. Individuals in their 30s, 20s, or even early 40s that have no cognitive symptoms. And we have been trying to use every tool that we have to detect some of the earliest changes in cognition that can actually tell us who are the ones that are going to be developing Alzheimer's disease or memory loss in the future. And I can tell you by experience that the measures that we have available in neuropsych, they don't work. They actually don't tell us who are the ones that have any impairment. And in the past few years, we have been making a really extra effort trying to develop novel measures that can actually help us to identify those at the greatest risk. So we also have a big challenge in tracking the treatment change, for instance, in clinical trials in particular, that can actually help us to reliably track treatment change over time in individuals that are normal. So it's also another big challenge that we have there. And something that we are called to do something is like we have to modify, as I was saying, like, and also trying to improve the measures that we have. That's an option. And that's something that many of my colleagues have been working really hard as well, trying to improve the sensitivity of the current standardized test, and as well as advancing and improving the psychometric methods to analyze and using the measures that they are already in use. Some of them, the approaches that they have been using has been designed like using more sophisticated statistical approaches to use these neuropsych measures that are already in place, or using like cognitive composites that I'm going to be describing in a moment as well, trying to improve their sensitivity to detect those are the greatest risk. The other approach that some colleagues have been used, as I mentioned, have been also developing some novel measures that are particularly developed in the context of detecting those at greater risk and those that can actually be part of prevention trials. Next. So for clinical trials in Alzheimer's disease, as it was discussed before, so still we need to figure out the way to have cognitive outcomes that can actually help us to show some kind of efficacy in trials, and particularly in preclinical or pre-symptomatic or symptomatic trials, ways that we can actually show, as it was discussed, how this can be meaningful to participants and how this is something that can even slow decline or slow progression, or how this is going to be something that is going to show that the treatment or the intervention is going to be meaningful. Next. So now, as part of the improvements that happened in the past, now almost a decade, is the cognitive composites. And as part of this cognitive composites, so the development of this cognitive composite happened along the developments, as it was described in the previous session, of the biomarkers, particularly the biomarkers of Alzheimer's disease pathology. So the cognitive composites were developed along with these earliest cognitive changes that were tracking along the underlying pathology. And there has been like this development of using multiple domains versus multiple cognitive domains versus those that have been like targeting single domain composites, mostly the episodic memory composites. Next. The one that has been the most used in preclinical trials is the PAC, or the preclinical Alzheimer's cognitive composite, that probably all of you are familiar with. This was developed in the context of the anti-amyloid therapies, and it was first introduced with the A4 trial, and it was developed with data from 3 observational cohort sites, including ABOL, ADNI, and the ADCS, and it includes the mini-mental, the logical memory, delay, story recall, the digit symbol, the total recall of the free and Q, a selective reminding test. And as you can see by the subtest, our subtests that were already kind of like out there, and subtests that have been, I will call like traditionally used in neuropsych testing or patients with cognitive impairment and dementia. Also, as you probably recognize by the test, has been tested that are already pretty heavy in the verbal memory domain, and tests that also are mostly developed for English-speaking participants or patients in general. But this is the composite that has been around and has been used in these clinical trials. Next, sorry. It has been shown, and this is only one reference actually by Dr. Beth Mormino, but there are several others that have been actually shown that this PAC detects, is actually a very good detecting decline in clinically normal individuals that actually are amyloid positive versus amyloid negative, and it tracks really well with longitudinal decline. In this context, Dr. Kay Pal from the Harvard Aging Brain Study and others as well have shown that if you actually add, like for instance, like category fluency to the PAC, his ability to detect this difference between amyloid positive and amyloid negative individuals actually improve. So like adding another component that is more related to category fluency in this case improves. So it's already telling us that if you actually add something to the PAC that is more related to cognitive, in this case, categories and semantic processing, can actually improve his ability to detect those at earlier stages. So the PAC-5 that it was published in 2017 is kind of like one that is like a revised, or I would say like a little better version of the original PAC. But in addition to that, next. So we already know that the PAC has several limitations, And here I only list like some that are the most discussed. One is that includes the mini-mental, that as you also may know, the mini-mental, we know that it has very low sensitivity to cognitive decline in early AD. So like the same, we know that those that are very early in the disease process, or disease progression, they are usually really good at the mini-mental. So they could have a mini-mental of 30 for several years until they actually start declining. So as I mentioned before, several of the subtests are actually measuring verbal memory. So there is some kind of redundancy with the measures too. There are no alternate forms, which also is a limitation there. And there are no like executive function measures, though some people may argue that the digit symbol is actually assessing their executive function as well. So next. So definitely there is now like a switch showing that multiple cognitive domains may actually provide greater sensitivity to detecting those individuals that are more amyloid negative and are declining over time versus using only episodic memory composite scores, such as the original PAC. And Lin et al. In 2017, for instance, they validated a composite when they switched the mini-mental, they removed the mini-mental and they included verbal fluency instead. And they actually were able to show that this switching, it was a better, was more sensitive at selecting, detecting a decline in individuals that were amyloid negative compared to only the version without verbal fluency. So definitely, as I was saying, like some improvements as we go that can show that having these multiple cognitive domains can actually improve the sensitivity at detecting those earlier individuals at risk. So next. Also, the pointer is another example of using these multi-domain cognitive composites. So this is one of the clinical trials that is a multi-level lifestyle intervention, and they use a composite that includes several domains beyond episodic memory, and it's ongoing as well, and it's another example of going beyond the episodic memory. Next. Next. Thank you. And this is another example of composite. This is the one from the clinical trial in Colombia, the Alzheimer Prevention Initiative. This is the one that was created using data from the Colombian kindred, using data from 20 years of follow-up, and they were using the subtest, and that were able to distinguish carriers from non-carriers, and looking at the ones that were able to distinguish the earliest subtle changes in cognition. And as you can see, so there were some subtests beyond the episodic memory, including some changes in visual spatial processing and some changes in non-verbal processing as well. So like the same, they were able to show as well that using a composite that including subtests that went beyond episodic memory, and in this case, for instance, subtests that included non-verbal or abstract reasoning was more sensitive than even including the total score of the CIRA battery altogether. Next. So on here, I wanted to mention that the same, like in addition to everything that is included as primary outcome measure, that so far what I was showing is more related to the primary outcome measures that we have with the composites. So all these clinical trials and prevention trials, they also include the secondary outcomes. Something that I found very interesting is that there are some secondary outcomes that actually include some more neuropsychological measures that are more standard and traditional, or like a more new measures as well. So there is one, for instance, that is the ARBANS, that is a repeated battery that actually includes alternate forms. That is included as one of the secondary outcome measures. And there is another secondary measure that is the sum of boxes with the CDR, for instance, that also includes different like adjustment questions and so far. Or yeah, so pretty much like something that we will learn more that is included as a secondary outcome instead of primary outcomes. That is also important to consider. It's like other domains and other functions that are usually not included as a primary outcomes that usually we don't pay as much attention when we are thinking about these kind of trials as well. So something that to pay attention, I think that is important as well. So next. So how can we improve the cognitive outcomes? And this is something that I just wanted to mention this as suggestions because I think that is important to consider as well. So the first one, next, as going back to the first slide that I included. So I think that it's important to advance this point of developing new measures that can be relevant to the detection of subtle cognitive decline, keeping in mind, as I was mentioned before, what is meaningful and how we can actually include this as part of the trials. And in the next. So this is taken from one of the review papers that Dr. Doreen Renz and Dr. Mario Parra published in 2013, and pretty much raised the importance of using what we are actually learning and keep learning now to this point from cognitive neuroscience, and how much we are actually, as we get earlier in the disease process, how much we can actually use all this knowledge from cognitive neuroscience and taking it to what we are actually applying to clinical trials with individuals that are normal and that individuals that don't have any symptoms. And one example is like next. So these three tests, for instance, are three measures that we are actually using in the Colombian Kindred as an example as well, what is mentioned before, that when we first noticed that the standard neuropsych measures that we have available were not helping us to detect some of those earliest subtle changes in the individuals that we knew that they were at risk for Alzheimer's disease, we start going and using some of these measures. Next. So this is one of the three measures that I just showed. We start applying this one, that is the visual short-term memory test that Dr. Mario Parra was using. And we were able to show that this task that is, first of all, is visual short-term memory, so it's not episodic verbal memory. And we actually were able to show that this task was able to distinguish carriers from non-carriers very earlier ages, even earlier than the traditional, more standard measures. So like this, like a little reminder of the importance of thinking outside the box and going and using some of this knowledge that cognitive neuroscience has contributed and applying to what we are actually doing in the clinical neuropsychology, for instance. Next. Now, like improving screening tools for selection of individuals at increased risk. And here I wanted to mention this next, this beautiful study from my colleague KPAP and the Harvard University as well. It was something that was recently published, and it was mentioned in, Dr. Mormino mentioned earlier today as well. There is also a reminder of the potential of using home testing and supervised testing. So they use iPads, and also with the face name task, that it was one of the tests that I mentioned, one of the three tests that I mentioned before. So they give this test to participants from the Harvard University study, and they show that the ones that were amyloid positive, they actually have less learning effects in this task that was administered every month compared to the ones that were amyloid negative. So this is like another application that a potential we can have using home testing and supervised testing, and how this can help us to screen potential participants for clinical trials. Next.
About a minute left.
Right, yes. And finally, of course, I had to mention this because I think that is very close to my heart, is how we can actually increase diverse participation in clinical trials, especially when we know that diverse participants are actually a greater risk, and how we can actually use culturally and linguistically valid measures, not just translate the pack. And next, one of the things that I was mentioned before, like we have validated some of the face name instead of just using the same, like that's an example. Next. Also include the subjective report, not just going by the objective. This is one of the advances that we can consider. And next, to conclude, next, standard neuropsychological measures may not be optimal for prevention trials. Next, there is a need to improve our cognitive measures for better detecting and tracking cognitive change over time from preclinical to clinical stages. Next, composite cognitive scores need to be reassessed to make sure they are appropriately capturing change in relevant domains. Next, novel approaches like home assessments and mobile technologies can help examine whether more frequent or repeated or unassisted cognitive assessments may improve estimates or change over time. Next, there is a critical need to develop and use culturally and linguistically valid measures, and the same having a bilingual bicultural neuropsychologist as one of these presenters in this workshop is a big step in the right direction. So thank you for that. And next, thank you for your attention.
Wonderful. Richard, we have 1 or 2 minutes before the scheduled break. Was there a quick question that came in the chat to knock off, or else?
They're good questions, but I don't think they're quick.
Okay. Well, we will have the time to discuss them in the discussion section if they aren't quick. And that was a wonderful talk, so I'm sure there's a lot to ask about.
Yakil, we do have 2 minutes. I'll ask the question for you then. On the I mean, to me, it's obvious that we need to be working on language-based versions of measures and culturally sensitive versions of measures. Have you seen that there are subgroups of cultures we need to deal with? Because that's what I'm coming up with lately. You know that we try to do universal Spanish translation and I get complaints from 4 different Spanish-speaking communities. Have you touched on that a little bit? And I know that's not a quick question for a minute or 2 either, but can you comment?
Like, for instance, we were working on something similar when we were putting together like some versions from the Latin American fingers, for instance. Like, it was something that I was collaborating with some colleagues from Latin America to trying to harmonize the Spanish from Latin America. And even for that, as you were saying, like just, coming up with like a Spanish from Latin America is challenging because even from Latin America, there is not like a one Spanish from Latin America. But the solution for that is like just bring people from Latin America together, and then we talk and we come out with a consensus. And I think that was exactly what happened with that. Pretty much we come out with a consensus.
Thank you.
That's great. So it is a 5-minute break until 3:30, and see you then.
All right, let's get started.
Our next speaker is Dr. Richard Gershon of Northwestern University, speaking on remote cognitive measurement as an outcome.
Thank you, Jonathan. Okay, let's go to the next slide, please. So, we've just heard a lot of several presentations about the need for assessment and how to factor those in, and that the time period, I know Marty went down to 57, but but Jonathan indicated, as we know from lots of other research, that parts of cognition start deteriorating in the mid-20s. So how do we assess over life course? And when we're looking at the over life course, we can't pick a date, we can't pick exact time. So how do we do that inexpensively? So perhaps we have the potential of assessing many, many more people. And I know someone in the chat asked this, what's all of us doing? And I'll get to that actually in a little bit here. So we know prevalence of dementia increases with age, but we know that cognitive decline is part of normal aging, beginning in very, very early adulthood. But we're currently hampered by a lack of sensitive assessment tools. And Yakil went over some things that they've been using. And certainly things can be really easily and widely deployed. And if somebody could start the countdown to counter, I'll probably need less time, but 0 initially is probably not a good thing. And then the next slide, please. Thank you. Okay, so we're going to make the case for a mobile toolbox. Next slide. So, Sperling shows something, I think, again, Marty, several people have actually alluded to something like this in their presentations earlier today. And that is, we know that there is the upper line there, that there is natural aging, that there is some reduction in cognitive functioning in many domains actually. Okay, and then we know that we can probably detect dementia. We don't know how early we can detect MCI, but there is something earlier, right? And how early can we go, and can we have tests that are sensitive enough and to detect those changes? And I guess next slide. So, and then if we detect those changes, how can we continue surveillance for all sorts of potential therapeutics and interventions? And I'd like to also put in my pitch for those people who were talking about individual difference. I guess Nina's asked about individual differences versus group differences. As I mentioned at the opening here, these are group averages we're looking here on the screen. And so can we come up with assessment strategies that allow us to do more frequent testing, so we can have people serve as their own baselines, which right now is an expensive thing to do, but I think it's really necessary if we're really going to catch these changes, particularly if we're looking at way preclinical. We have to differentiate people and see that they're sliding down from their own baseline. Next slide. So the NIA awarded 2 grants, one to consortium led by myself and 4 other PIs, and I'll get into those names in a few minutes, called the Mobile Toolbox for Monitoring Cognitive Function, and second led by a team led by Murray Slawinski at Penn State, Ambulatory Methods for Measuring Cognitive Change. And I actually think that graphic was in Marty's slides. So we're doing a little bit of double duty here. Next slide. And here's the team. So I need to recognize my co-PIs, Aaron Cott, Mike Weiner at UCSF, Doreen Rentz. It's been mentioned several times. I don't know if Doreen's on, but the author of the name tests and other things, and a cast of people from around the country. A big group at Sage Bionetworks, led by Laura Mangerby, who were the people who developed a lot of the original materials in Apple Research Kit. So enabling Apple phones to be used to collect research data easily, and then Marty's team at Penn State, which is also a national team as well. Next slide. So the thought process here is, if we're going to collect early on, we've got to do it inexpensively. We have to do it using ways that we frankly don't do right now. And obviously we have, people have been doing web-based assessment, but what if we could create something that people ran on their own computers? And their own computer of today is really the smartphone. A decreasing number of people have a larger computer. And smartphones can do a lot, and yet, relatively speaking, not a lot of work's been done to develop those measures. So you've seen some earlier today. I always want to remind myself, I think the iPhone's 12 years old this year. It might be 13. My calendar's a little off with COVID. So, and we would create measures for the system from NIH Toolbox, Center for Healthy Aging, the International Cognitive Ability Research Kit. Research Stack is an underlying library developed out of Columbia that does the same thing as Research Kit for Android phones. And then, of course, a face name test. And we'd also be able to deliver additional measures of variables such as mood. And I think Janine Simmons brought that up in the panelists, echoing Jason Flatt's question. I'll get a little bit more. Are there measures we can put in the system that can catch social variables as well as mood variables that may be either important covariates or it may themselves be predictive of cognitive decline? Next slide. So, but having said that, we put a lot of emphasis and probably half of our total funding into creating an open source repository that people could easily include in their own studies. Because everyone on this call has developed their own software tool or their own platform for doing that. When you get into mobile, now we got a whole new game if we want people using their own phones, right? Apple, I always tell people, Apple updates its operating system 8 times a year. They make money by doing that, by coming up with new phones. Android does the same thing. Android's got a much wider user base. So how do we come up with a system that we can put these measures in and yet gather data and support studies across a wide range? So we're going to create a research platform. We're going to put it in the public domain and have people use that platform or be able to develop their own using those measures. And the platform we're using was developed by Sage Bionetworks using the original launch of the 2015 Apple Research Kit. So ultimately support researchers to contribute their own measures, select assessments, fully manage a study in advance or in real time. And advance meaning you can set up a study, gets transferred to a person's smartphone, and they don't really need to go online in the middle to be reminded that assessment's happening. Create assessment store programs, get that data back automatically, store it, aggregate it, analyze it, and share as appropriate. Next slide. So, if you add up the apps on an iPhone and now Androids, you've got 98% market share in the United States at this point. I don't have the numbers here, but if you read the Pew Research, the number of people certainly along the aging continuum, more and more have smartphones, and smartphone use in communities with disparities is pretty high, and certainly higher than their access to a computer. iPhone and Androids are stable platforms at this point. Distributing iPhones or apps for phones is effectively free, increasing uptake. People are willing to spend a lot of time on their phones. They do. And Apple, based on their feature about a year ago, they remind you every day or every week how much time you spend on that phone. We can put these programs and databases together. In addition, these phones have a lot of sensors in them. They can record movement. They can record all sorts of things, and those measures are easily aggregated. And indeed, ResearchKit and ResearchStack have dozens of existing measures people can already add in, and the platform we've created can easily include those measures. Okay, next slide. So here's a quick list of measures that are in here. You can see on the left NH toolbox measures. We'll get into those a little bit more. The 9 draft measures from the MTC2, which is put in there. The lower left-hand corner are a group of measures from a Syntrax consortium, and on the lower right-hand corner are RDoC measures that are nominations that are being field tested by National Institute of Mental Health for inclusion in all of us. So all of these are being done. Let's look at some example. I'm sorry, in addition to these measures, not on here, we have, as I mentioned, International Cognibility Resource. That's a platform put together by David Condon and Bill Revell, both originally in Northwestern. Bill's still there. A whole series of measures. They collect 5,000 subjects per day worldwide. We're filling out primarily personality measures. We're putting in measures from the patient-reported measurement information system, or PROMIS, which therefore includes some of the social measures that people have been asking about before. All the toolbox measures, PROMIS measures would be available, and the platform would be available in Spanish. Okay, let's go to the next slide and have a quick look. So these are formatted for phones. You can see now we're trying, I'll talk a little bit to trying, originally our goal at Northwestern was to come up with tests that parallel the NH toolbox, which has been widely validated in aging research and detection of cognitive decline from ages 3 through 85, although we're catching improvement in cognition prior to decline. So you can see we can put a flanker test on a phone, number match in the lower left-hand corner, upper right memory for sequences. And although most of my faculty said we're not going to try picture sequence memory, we indeed have done that and put that on a phone as well. Next slide. A face name test, which Akil mentioned and others have mentioned, we've formatted for use on a smartphone, a DCCS, dimensional change card sorting task. Vocabulary, the current NH toolbox uses a picture vocabulary test, but we moved it to able to acquire a library of 40,000 calibrated words, so created a computer adapted test for vocabulary. And in the original toolbox, we have an oral reading test, which is also computer adapted, but required live scoring. As much as technology has increased, the accuracy of things like Siri are not good enough for reliable assessment. So we created a spelling test, which actually gets very close to looking at the same underlying constructs as oral reading. Next slide. Okay, so NH Toolbox measures were drawn from the NH Toolbox for Assessing Neurological Behavioral Function, which was originally a contract from the NIH Neuroscience Blueprint. I was the original PI for that contract, and we continue to distribute that. But they added 40 measures across cognition, emotion, sensory, and motor function, and which were based on a survey of 250 epidemiologists and clinical researchers funded by the NIH with an extensive literature review. So really our sets of measures across those 4 areas. For Mobile Toolbox, we're currently concentrating on cognition and emotion, but we actually do believe we can do, there are people who are using sensory measures such as odor identification with COVID, and I think we'll get it down to a phone format as well, though you have to have the scratch and sniff cards. But we got the scratch and sniff cards down to under $1, and in volume, they actually cost a lot less than that versus $20 or $30, which more expensive test costs. And motor function tests we can actually do using the sensors inside the phone. So working on doing those things as well long term. So the toolbox so far, I mean, through 2019 was being used actually with close to 1,100 sites. And we've later determined more than 150,000 subjects in English or Spanish. So we're trying to do is take a tool that was designed for use for a live test administrator and getting it to be self-administered on a phone. So we found measures that mimic those domains, particularly in cognition. Next slide. So in M2C2, task paradigms were based on a theoretical and empirical support stemming from their information experimental models that had evidence of age sensitivity and or sensitivity to age-related neuropathology. And they concentrate on using stimuli that can be randomly generated or drawn from large item banks to avoid really specific practice effects. Because Martin's group does a lot of work with EMA, environmental momentary assessment, first design models where you need a lot of content, but the advantage I think Marty showed earlier that we get intraday and intra-week variability with performing, and so to get around that, give a lot of very brief tests, which will certainly can be argued as the average of that is a person's true functioning. So brief administration times, exhaustiveness and sufficiency of scores, and very minimal technical requirements, which apply to both sets of measurement systems being developed. Next slide. So measure selection norming validation. So construct validation for the toolbox versions of those measures actually starts on Tuesday. COVID put us back close to a year on that, but we wanted to really validate against in-person measures. So we're testing in person, we're testing remote, we're testing retest, we're testing bursts and EMA designs. We're also doing clinical validations for people at risk for MCRAD, ADRD, cognitive impairments. We've got a group at the Emory Healthy Aging Study. They have a repository of tens of thousands of their own patients they're carving over time. Doreen Rent's got a group with the Harvard Aging Study. Einstein's got an aging study as well. We've got Emory's cognitive impairment. Parkinson's, we're also validating it. It's a group that's been tracked online with Parkinson's disease, UCSD's associated neurocognitive disorders with HIV, and then the Healthy Aging Study at Emory as well. So we're also norming measures in a national sample with multi-month looking at change scores and learning match, and that whole thing is matched to the 2020 US Census. And we'll be doing something similar in Spanish later on. I should put out that Sandy Weintraub, frequent collaborator of mine, we look at, I was glad, I think it was the Yakil's slide related to, and also Mary did something similar. And we've got these retest effects, but I would look at considering it's more norming learning effects. And I think there's a big discrepancy between the learning that a person that's not impacted by dementia, cognitive decline, versus someone who is. And we can actually model that versus, people are always worried, oh, there's retest factors. I'm not seeing that with people who are having cognitive decline. They don't get the learning as much, and we can model that, I think, across all of our tests here and the tests others are developing. Next slide. So just a quick overview. You would be able to create a study online. It gets deployed by smartphones. You send people a link to your study, generates data. That data is automatically returned in the background from people's smartphones. You're able to monitor compliance online. You can have the app remind people inside of it, or you can, so you can set up reminders within the app that pop up on their phone, or you can automatically text or email them. The system aggregates all that data across any phone type, across different models, and we'll have to learn over time what the differences are. iPhones and Samsung Android phones have high resolution timing. Some of the cheaper Android phones, you would not be able to count on the timing results. The system is capable of analyzing data within the system and disseminating it, or you can download the data for your own analysis. Next slide. So build your own study using existing tools, bring your own, so add your own measures, and then we're hoping to create a centralized platform for data dissemination so people participate would voluntarily distribute de-identified data to others. Next slide. So you have build your own, so some samples of screens. So just using the models that are there. Also, we'll have open source copies of all the binaries for people who need to do it on their own, and have the development staff to do that. You'll be able to download the measures and include them into your own studies and using other different technologies. Next slide. So these are really teeny. So you select assessments, configure the study program protocol. So if you have an EMA design, how often you give the test, any kind of design, how often is the test given? You could set up a multi-year longitudinal design. You can change the study design remotely and have it'll upload to the phone the next time that app contacts. Okay, and then you deploy it on the participants' smartphones. Next slide. You see in the lower left-hand corner, you can monitor compliance, who's doing it, who's following through. You can put automated data analysis, so you can create tools that work online in the system. You can actually use the results of those analyses to change what tests are being given, or you can just do that, and then obviously all sorts of distribution tools. And again, if you don't want the online tools, you just download the data and do your own thing. Next slide. So where we're at, we finished developing these tools, validation, study, testing, literally. We've done lots of field tests, but validation starts on Tuesday. Yay, finally. Actually, our general population norming also starts, not 2022, also starts on Tuesday. We decided to go in parallel. We did enough field testing that we're confident that our validation results will be fine. And we'll, generally speaking, put this in the public dissemination 2023. Clinical testing will begin late this fall and early next winter, and probably have some room for people to twist our arms to get on board a little bit earlier. Next slide. Oh, that's it. I got my 2 extra minutes in. I could answer, what I'll do is I'll answer Janice's question as part of this presentation, at least relative to these measures. The question was, are there systematic efforts within neuroscience community or elsewhere to develop measures to detect potential non-cognitive, e.g. affective or social changes that might predict, reflect dementia? So I didn't present another project of ours, and that's Armada, which is the Advancing Reliable Measurement in Alzheimer's Disease and Cognitive Aging. That's a project to validate the NH toolbox extensively on ages 65 on up in normal controls, people with biomarkers for MCI or AD in both and general population samples, the whole thing again, African-American sample, and the whole thing again in Spanish speaking. Our early results have found that in the social domains that indeed self-efficacy does a very good job of discriminating MCI from AD, and also anger, physical aggression. These are both promise measures, differentiate MCI and AD, and they're also, NH toolbox emotion measures. Along those lines, there are other tests that could be done remotely. The toolbox found grip strength, pegboard dexterity, 2-minute walk and gait speed, which many people are using to track, to detect dementia. But I think 2-minute walk and gait speed probably can be detected automatically using smartphones as well. And we have found odor identification of words and noise can differentiate normals from MCI versus AD. Some of it may be, knowing that a test detects something like dementia or detects cognitive decline, it may not be the domain as much as how it's given. So some of those tests we'll have to see, can people who have decline, they don't understand the instructions for dexterity, but because of that, we can detect it anywhere as a direction of dexterity. Okay, with that, I think that's about it. Time to move on to our next person, and we can queue up Lauren.
Great. So hi, everyone. Thanks for having me. I'm a health economist, so my talk is going to be a little bit different from the more clinical and biological measures that we've been talking about so far. Next slide, please. But I wanted to sort of cue us back to sort of our underlying thoughts about dementia, which is the fact that it's a disease that really interferes with a person's daily life and activities. And what's really sort of useful about some of the data sources that I'm going to be talking about is it potentially gives us sort of a window into some of these mild stages where we're just beginning to get effects and changes in underlying functioning, where we might want to both see a trial preventing and also opportunities for further intervention to help patients. So the next slide, please. And so especially as we become increasingly online, our daily lives produce really useful symptom trails for potentially tracking some of the consequences of dementia that we're particularly worried about. So the example that I'll be talking more about from my work is understanding the financial consequences of cognitive decline. So we know anecdotally and are beginning to see in data as well that early stages of dementia can include activities like forgetting to pay bills, having difficulties managing money, suddenly becoming more impetuous in your financial behavior, which can include uncharacteristic purchases, being increasingly susceptible to scams, and suddenly changing your portfolio composition. On the behavioral side, we see personality changes, changes in speaking and writing. We may see Google searches for new symptoms, as has been noted with other diseases, as well as some of the mobility consequences. So this means we might see people getting into more car accidents or sort of recognizing their difficulties driving and increasingly using things like Uber or Lyft to get around. Changes in fee data, as other speakers have noticed. We might also see either a new reliance on using map applications, suddenly starting to return home from destinations we wouldn't expect that might be consistent with wandering or otherwise getting lost. And these are all patterns that can potentially show up in large data sources that are not traditionally used for monitoring dementia, but potentially could be. So next slide, please. Next slide, please. And to give an example of some of the work we've been doing using consumer credit data to detect signs of dementia, is a long-running project where we've linked Medicare claims data to about 20 years of consumer credit report data with the Federal Reserve Board of Governors, tracking about 80,000 single Medicare beneficiaries. So single-person households are especially nice for this type of research design because you can link the same person's financial and cognitive behavior without having to worry about a more cognitively unimpaired spouse potentially taking over. And we explore changes in rates of adverse financial events as a function of time from dementia diagnosis in comparison to those who are never diagnosed. We also want to determine whether ADRD has a unique financial presentation. So it could be that we just see changes in financial behaviors that are characteristic of aging or becoming sicker or other potentially confounding events. And We can also look at whether financial events at a specific point in time are predictive of developing ADRD in the future. Next slide, please. So I'll sort of summarize our results in a few plots. This first one shows credit account payment delinquency, which is being 30 or more days overdue on a credit account. Most of these are credit cards, but it can include other types of consumer loans as well. And being 30 days overdue means that you've missed at least 2 cycles worth of bill payments without realizing that, oh, you know, this is a day or two late, and corrected that. This horizontal line is basically where those with normal cognitive functioning are, and you can see that more than 6 years prior to this time of diagnosis right here, there's an elevated risk of missing payments. This actually continues past time of diagnosis. We were sort of hoping that there would be a recognition and family members stepping in, which doesn't appear to happen, but that means that we have this sort of useful signal in the data for even longer. Next slide, please. We also see dementia-related financial challenges leading to increased subprime credit scores. So the credit score is a good summary statistic of your financial behaviors across a number of accounts and sort of reflects the likelihood that you would repay a loan in the future if it were made to you. And subprime credit suggests that you're a pretty high risk. And so this is going to be the accumulation of previous financial mistakes. And here we see that the risk of subprime credit increases about 2.5 years prior to the formal clinical recognition. And this is clinical recognition in terms of having a healthcare visit with ADRD showing up as a diagnosis somewhere. Next slide, please. As I mentioned, we want to make sure that these financial behaviors are relatively unique to dementia and kind of not driven by other confounding factors. And so we also looked at arthritis, where you can see basically no changes before and after diagnosis, and across those with and without arthritis during the study period. Again, relatively little going on with glaucoma and hip fracture. The one other health condition where we do see some associations with financial events is heart attack, and that is a condition in the literature where we've seen financial stresses, which missing bill payments could reflect as being a potential risk factor for heart attacks. So again, not surprising to see that, but certainly highlights the fact that dementia is not the only health condition that may present in credit and other forms of financial data. So next slide, please. We've also started to look at how useful having credit data at just a single point in time would be, and using that to predict whether a Medicare beneficiary develops dementia in the future. And we do see that those who have higher predicted risk scores, strictly based on either credit or credit and demographic data, are considerably more likely to develop dementia in the future, although we're still quite far from having something that you would want to use for diagnostic purposes. And certainly many people in our data miss credit payments without that being a sign of dementia, for example. Next slide, please. And so for the remainder of the talk, I wanted to note some of the other potential found measures that we could be using and strengths and weaknesses of this type of approach. What's really nice about them is they're already out there just waiting to be incorporated in research, relatively low cost and low burden to any type of data collection that requires participants to really do anything other than go about their daily lives. These data can be very high frequency, allowing us to focus on pretty narrow time windows, and near universal participation can get us very large samples and high retention rates. So we think these types of data can really help us understand how dementia is impacting daily living, and not only monitor symptoms, but devise tools that can be used for ADRD detection and protection in things like financial and other settings. Next slide, please. There's also a number of challenges that would need to be addressed in this type of work. Certainly privacy is paramount. A lot of these measures themselves are sensitive, and doing the foundational work that we need to sort of link these measures to an ADRD status requires linking to a second sensitive data set, and just obtaining the permission for some of these retrospective linkages can take a number of years. I think we were getting close to the no cost extension in our R21 that started this study when we finally had all of our data in hand. They also require putting together often disparate data sets, multiple skill sets, and institutional knowledge. And we often want really even more than 2 data sets. So our combining the consumer credit panel with Medicare claims opens up many, many avenues of research, but we only see how participants are managing debts, and we'd really like to see bank and brokerage accounts so that we would be able to understand the host of other financial transactions that could signify cognitive decline. And some of the other things that we'd be interested in, like for example, car crash data can often require things where all 50 states have their own separate system and they may not be interoperable yet. Next slide. Another challenge was sort of thinking about how do we design the prospectively collected study is that the measures we want may become obsolete, right? So if we 20 years ago we had started this trial, we might have thought that we could look at changes in Friendster posts as a way of tracking people's abilities to communicate in written form. We would have had to transition to Facebook, maybe to TikTok, and then who knows what the next data set would be. So sort of thinking about things that can be relatively stable going forward is definitely beneficial. And then we also have to deal with kind of technological change and automation that may also make it difficult to track our outcomes. So like in our study, we worry about people who have automatic payments, and then they would not miss bill payments even as their cognition declines because they'd set up auto pay. Similarly, self-driving cars can potentially in the future remove signal that we might get from driving data. Next slide, please. I think there's also sort of continuing the challenges, but also thinking about how these are opportunities. Certainly we need more validation studies to identify which are the most promising metrics, which could be a very nice research and investment opportunity. This is also an area where we would likely be able to use this data set to study a number of diseases and interventions where improvements or a lack of decline in functional status is going to be a very useful endpoint to track. So something like prospectively consenting participants into something like a health and retirement study of passively collected measures would open up a lot of amazing research opportunities. I'm pretty sure that there's marketers and browser cookies that are already doing what the research community would hopefully be able to do. So maybe it's a question of tracking those people down and figuring out how we can get them to share data. But I think probably also some targeting of especially relevant outcomes. Next slide, please. And so I think just some of the summaries and implications are that there's a number of existing data sources that probably contain a lot of information about dementia-linked changes in daily life. We need a lot more kind of foundational research to isolate some of these relationships, but that could be happening at the same time that the trial is proceeding if we're either collecting things as we go or you know, if the trial had been running for 5 years already when we discovered that there's some utility in using the credit data, for example. All of the credit bureaus keep historical records and kind of rely on that to look at changes in individuals' credit behavior. So it's relatively easy to get some of those measures retrospectively. Others might kind of be less easy to recover. And it's an area where access to and partnerships with private sector data sources would be really helpful. So I included just a few examples of things that I would love to be able to access. Kind of Amazon shopping histories, right? Or are you suddenly buying kind of crazy things? Certainly credit card data would make it even easier to aggregate all of those changes in behavior, FICO scores and other forms of credit bureau data. Google Maps, your insurer would be able to tell us if you're changing your driving quality. And we've talked about cell phones is a useful source of potentially testing, of measuring mobility, and also this tends to be sort of the last bill that you stop paying. So sort of missing a cell phone bill is going to be a sign of some major health challenges. And so I think those are the main points I wanted to bring up, and I'll leave a couple minutes for the discussion section.
Thank you very much, Lauren. The chat room is now open, but whoops. Okay. There's systematic errors. I'm missing that. I think we answered that, didn't we? But I'll put it back. I'll re-echo Jessica's question, which I think mimics Janine's question. Are there systematic efforts to develop measures to detect potential non-cognitive changes that might predict reflect dementia? Is that already part of all of us? So, I mean, my understanding is all of this cognitive strategy is not in place yet. At least that's my meetings with NIMH in particular, but they're looking at various things, but that's not finalized. But certainly should be there. Something should be there. Is anybody else on the either panelists or anyone who's joining us today know more about all of us's cognitive strategy or non-cognitive strategy?
Some of us might know more, but might be able to say less.
Got it. You look like that kind of guy, John. Okay, so Lauren, I'm going to ask you some things though, because so when it comes, you actually earlier I was writing notes about passive data collection, which you've got in here. Talk to me about tell us about individual predictive capability of these things. Clearly, the relationship is there. And I mean, I certainly could see ways of doing it. And I certainly could see ways of combining the data you had and combining with some of the other measures, which other panelists have brought up. Have you looked at that? And particularly when you've got the problem of, it looks like having a heart attack could give you the same kind of markers. So how do you see differentiating that on an individual basis over time, or is it too early to talk about that?
Yeah, so I think we're at the stage where we've run the models that suggest that there's signal, and also at the stage where you wouldn't want to use the models that we've produced so far because the sensitivity and specificity isn't really where you want it to be for like giving someone a diagnosis. We think this is sort of something that could be used, sort of like you said, at this stage, kind of in conjunction. So I think a lot of clinicians will say, oh, you know, it's helpful if you can get a patient to show you their checkbook because you can see, you know, where it stops making sense, and sort of use that as a marker, and where we're trying to do the big data analog of that, but being able to bring in other pieces of both, I think, the health and the daily life functional impairment would vastly improve some of the predictions, as well as looking more over time. So we sort of deliberately said, what if we just take one snapshot? Does it have any signal? And so that's sort of the least demanding thing you could do with the data, and it promisingly seems like even just 1 year of your credit data later in life is useful for doing some prediction.
I'm going to ask you the same question, but I'm just going to comment that, I mean, I certainly see combining with some of the measures, you know, that we're putting forward in the mobile efforts. I'm sure Yakil's some of the composites there. I mean, what's unfortunate is, and it's not practical because of burden, you know, put all these things in a hopper, because I think, you know, we all have, you know, our specificity is not exactly what we want it to be, right? Particularly when it's clinical. Research side looks great. Area under curve analyses look wonderful. But you know, nobody wants a false positive MCI or AD diagnosis, right? You could actually have really horrendous impact on someone's life. And also flip side, if you miss it, it's a problem. I'd almost rather miss it than give someone my personal value judgment. But it would seem to me by combining these different modalities, we're more likely to hit things. What do you think, Yakil?
I wanted to add something related to that, but also like to what Lauren was saying. I think that also related to what Marcus was mentioned before. I think that a key component that we are missing, or is also there, is like the informant, right? Like, and it's also something that is key in all the studies, and also when we are thinking more like in the midlife and everything, you know, like it's not just the self-report, it's not only the objective measures, it's also like having somebody else that can tell us about, like, you know, how the participant is behaving, or if the participant is changing or is not changing, how the participant is functioning, you know. And I feel that that's related to what you were saying, like, you know, like if we notice any change in the ability, if somebody's not noticing that change in the ability to pay the bills, you know, if somebody's actually noticing a change in their abilities to remember things, you know, like having somebody to report. I think that the informant is something that the preclinical, even the prevention trials, include that data as well. So that component is something that is very important. And I didn't mention it in my presentation because of time, but it's also something that we collect, and it's very key having that report too. And as you were saying, it's also part of the data that we have. And it's not just burdening the participant, but it's part of that, having that data there that can be very, very relevant and important.
I certainly agree, although I've been very fortunate. I've met bi-weekly with many of the EMRs, and particularly Epic, for the last almost 10 years of helping them strategize how they're putting measurements built into their systems. Because I really feel when we're all done, we have all this great research results, but if we can't get it built into the annual wellnesses into clinical care, and to the best of my knowledge, and I'm only weeks away from last asking this, they have no structure within Epic system to collect informant data. They can't give a link to somebody to give that. And so actually we're working on a clinical trial right now, giving somebody measures to the toolbox in the part of the annual wellness visit. And we know that, informant would really improve that model. No way to collect that data. We can collect it in a research study because we can do something, but no way to get it. Luke Stokel asked for Lauren, what do you think might need to create more fruitful public-private collaborations, especially accessing data from these various companies, sources, or research relationships do not yet exist?
And I think that's a great question, and sort of definitely one of the challenges of this is partly just getting the right people in the room, finding the doors to knock on. I think it, unfortunately, is at this stage still quite helpful if people have had personal experiences with their family and realize that there's sort of important reasons to do this. And the other, of course, is having companies see value in their participation. So in some ways, kind of like the credit data is nice because it's something that they sell anyway, and there's a representative you can sit down with who's sort of well equipped to do that. And I think some of the sources that we're suggesting haven't necessarily been used in research in the same way, and would take a little bit more kind of knocking on doors and persistence. So I think the other barrier to this is just, the time investment to get permission to do all these things. And that involves a little bit of speculation and buy-in on everyone's part.
Lauren, are some of these things though really already there in Facebook? You know what I'm saying? Some of the mega corporations at this point have so much data, and they have successfully figured out how to access these things that if you get past the privacy or get people to give you permission, you could literally do a lot of what you've got there through relationships Facebook already has. I know you said you're hoping you want to get in with the credit card companies, but these companies are doing this without us. The question is how to, do they have a health strategy?
Mm-hmm. Yeah, and I think if you look at, if you take your browser protections off and sort of use Amazon as a naive user and look at what they track it across sites, I think they probably have very sophisticated models already. They may be predicting dementia, and while they don't have a way of validating it like we do in our data linkages, I suspect that half of what we need is already there. Probably a well-protected trade secret, but one that could be, I think, used for better purposes than current applications.
Better purposes in making money? I can't believe it.
Well, but go ahead.
No, I had a question for you, Akil, actually, about the subjective cognitive decline kind of variables. You mentioned that, and now that you've got the PAC and a lot of these things in multiple trials, have you been asking the subjective cognitive decline questions in the same people you've been getting the better, more objective PAC data from? Is there a signal to be found there that would be amenable to, a shortcut essentially?
So there is even I think that in the AHEAD trial, they're using the CFI, that is one of the measures for.
Right.
Yeah, they are using that one. So the data is being collected, and they're using the PAC as the primary outcome. So yes, so it's being collected as one of the measures.
So this is great. So in a few years, we'll actually have the cognitive decline data in the same trials as the. Okay, this is the kind of thing I like to hear, because then you can start to sort of find out, even if it's not going to be the best outcome, if it really shows that it sorts well in terms of risk, even that would be great, because that's another big problem we have.
Yes.
Sorry, Richard. I just wanted to make sure I got that one in because
Fine.
Because our use of money and medications question in the HRS is just so predictive. It's not funny. Yeah.
So Maria Gleimer asked us something which I think is actually a multi-part question, but either read it, panelists, or I'll read it anyway. But for the goal of evaluating early interventions, we don't need clinical precision so much as likelihood of detecting improvements or delays in decline at a population level. I love Lauren's credit work, but 7 years is actually not that long prior to diagnosis. We need something that detects change at least 15 plus years prior to diagnosis. What are they, or are there efforts to explore heterogeneous found measures very flexibly? So Lauren, have you found things dating back earlier than that? Although I actually think 7 years is an improvement. So I think both are good.
Yeah, part of the challenge in our work, one is just getting a large enough sample, and so 80,000 in some ways is a large sample. In other ways, when you want tons of power and precision, we have a ways to go, and we are working on a much bigger linkage that I think will allow us to go further back in time. The other one was diagnostic processes weren't great at the beginning of our sample, so we just don't see very many people who have coverage in both of our data sets earlier on. And so as where we're getting better dementia detection showing up in the CMS data and kind of longer observation periods, in addition to there's a number of financial events that we haven't been able to look at, sort of running into the problem that many of the older adults we're starting with already own their homes and aren't eligible for things like foreclosure. I think there's definitely potential to better understand these as we get more data and longer panels. And so having the preliminary data from this smaller linkage, I think really helps us get to the next step of building these things out.
Molly, are you raising your hand?
Yes, I am.
Okay.
I'll even turn on my camera. So this is a question for Yakil, but perhaps for any others. So the issue that I think many of us have been struggling with for a long time is the notion that perhaps there's more sensitive neuropsych measures out there that can help us detect cognitive decline much earlier. But perhaps there's just not cognitive decline that much earlier. Of course, you have a cohort of individuals with the autosomal dominant Alzheimer's disease that would be a perfect group in which to test this. What are your thoughts about that? That yes, we may continue to look for more sensitive measures, but maybe the cognition changes are not, the very subtle changes are not going to be there until maybe disease is a bit more instantiated. And has your group been looking, or anyone else, been looking at other types of measures, such as in the motor domain, emotion, or even the sensory domains that perhaps could detect change in prediction of Alzheimer's disease much earlier?
Thank you, Molly, for the question. So to answer the last part, so yeah, so pretty much we have been looking to pretty much all the domains, because we are actually trying to see which are the earliest changes and the subtle changes that we can detect. So we have explored all the domains, and this is ongoing work. So we have, so visual spatial, psychomotor, as I was showing before, like a visual memory. So we have some paradigms and different tasks and tests. So the main thing and the idea that we follow with this test is that, as you were saying, like with the population that we have, so we know that these individuals will develop the disease. So the idea is that we actually can't use measures that can distinguish carriers from non-carriers without symptoms. And if these measures are sensitive enough to detect individuals without any kind of decline or any kind of symptoms, that is, we actually take those measures to individuals without the mutation, or in this case, without any risk, that those measures can actually help us in the clinic to identify those that have greater risk. And that's pretty much now what we're doing with this. And like, unfortunately, I didn't have time to show the face name, that it was the last part. With the face name, like for instance, that's where we are now. Like we developed some norms. That is the last stage. We actually developed some norms even within the clinically normal range, or different levels, or like a standard scores within the normal range, or how far individuals can be away from the norm, and how at risk they are based on how similar they were from the carriers in these families, using these families as a control, pretty much like the carriers, how similar they were from the carriers at a certain age, using that as a risk to develop dementia in X number of years. So it's kind of like using the carriers using the carriers as those that will actually have greater risk to develop mild cognitive impairment and dementia, even if they have no symptoms or any kind of decline. I don't know if I can explain myself, but that's pretty much the idea. And that's the main goal, pretty much. So we have in different tests.
So that was great. I checked. Jason Hassenstab's not here now, but he's been doing some work again in with respect to the Diane cohorts, and actually using mobile devices to try to find out if some of these more sensitive tests, will turn out to be indicative of change of state. And it's really interesting possibility. And moreover, because the dominant carriers are in fact earlier in life, some of the confounds you would get from just the later life and aging processes may not be there. So it'll be interesting to see how that worked.
John, we have a couple more things in the chat here. I don't know. I think our time's about up. I don't know if you want to put them into the wrap up, or
is one of these from Liz Nielsen?
Yes,
boss?
It is. Yeah.
Oh gosh, guess what? I think that's a good question.
More of a comment. It's just more of a comment. It's more sort of this idea that if we're really thinking of a prevention agenda in the long run, we're thinking about something like the diabetes prevention program, where you go to the gym, right, and get it. So we won't be measuring or diagnosing this, for the research evidence base. Yeah, it matters whether these are predictive, but for the long run, overarching public health agenda, probably we won't be giving everybody all of these assessments. So the research program is to work out which ones are most predictive. That's all.
Good point. We also have Marcel indicated the sprint study did adjudication. How would you use the information here to adjudicate? Just throwing that out there. Marcel can't get a microphone, right?
This is Marcel Salib.
Yeah.
Is there a way to get him a microphone? Maybe not.
All right. Last comment was Peter Rapp. Differences in the trajectory of practice effects seem to be a theme across several presentations. Are these domain measurement specific or present across tests? I'll take that first. They are indeed domain measurement specific. Memory tests, have ordinarily, you can give the same memory test a year later and you'll get score improvements in normal cognitive functioning. and other tests you can give repeatedly, and you don't get those. So I would say they're inconsistent, but I think they can be I personally think that a lot of them could be normed, and so you could use that. I don't know, Nikhil, do you want to add to that?
Yeah, I think that I agree with what you were saying.
Whoops, Luke. Tamales printers. Go ahead, Luke.
Well, I was just going to say, I mean, I put it there to read, but if so I guess to Molly's point, I'm thinking, trying to channel what Janine said earlier about not, so-called non-cognitive domains, and just thinking about entire functional domains. Like I use interoception as an example, where we've been using things like heart rate variability forever. And, but it seems to be an incredibly important, function. It's all the rage in cognitive neuroscience. And, my guess is there's not a lot known in AD and ADRD, especially in its role for potential markers and prevention. But, do we need to focus on better measures for interoception? So if we're still using heart rate variability, is that the issue, that we've just had this same old measure? And if we do a better job of measuring it, is that the problem? Or like I'm thinking about emotion, we're using just different types of measurements mostly. So we use, you point to the PROMIS measure, Richard. So most of those are like self-report measures, where what we're talking about in the cognitive domain are performance measures. Or you have, other areas like social cognition, which are, person to person, inter-individual, kind of assessment. And so you're talking about completely different contexts for assessments. And so I think that I guess one question that comes to my mind is, these are all, we're introducing variability here. And so when we're trying to isolate, specific domains, map them onto brain systems that we think may be disrupted in AD, that we may be able to detect early on, how much of that is a big problem? How much do we know about that type of variability, as we think about better measures for early detection for prevention trials? I guess that was kind of my summary of some of the comments and thoughts I had. That's more of a question.
I do think that Molly Wexler and I've had this conversation before, are emotional self-report measures objective measures? And I think that the research basis is showing, that they're, almost all emotional health measures, are still self-report. You know what I'm saying? It's we may not call them self-report, but an MMPI is self-report, measures that are used, and they've got incredible predictive reliability, and sometimes as much as cognition performance measures, which we consider those to be objective. There's a philosophical difference here, but I'm going to get back to some things I was saying with, regarding Lauren's. I think that if we can circle the wagons from all these different directions, I think that's where we'll probably ultimately win. And while I agree with, Liz, that this is a public health issue and all said and done, the more we can get these into, self-report and passive data collection, be it from credit bureaus or, you're doing some self-report, and I think the accuracy will be there over time. I actually think you can do some, if we can find out that there are, and we're so premature to this, right? If we can find out that indeed there are individual things we can work on. It's not just diabetes in general. We got to get everybody healthy, and we got to reduce obesity in general, but we may be able to circle in. When we were discussing the basis for this conference, I want to say 4 or 5 months ago, I'm thrilled, Lauren, that you joined us, Yakil, as well, because we're talking about that, how do we do some of this research in the context of 5-year grant programs, right? Because a lot of the things we're talking about, we're talking 7 years isn't enough. We need to be able to go longer. So we either need to convince the NIH and the powers that be that you really need to have funding that goes 5, 10, 15, 20 years, or we have to use more, or we have to use more retrospective data. I'm saying, which are in databases, and we're finally entering an era where there's got a CMS database that's 20 years old and things like that. And I think these presentations highlighted the potential of using those systems, but we have not certainly exhausted those areas at all. All right, Jonathan, give us a day one wrap up, please.
A day one wrap up. The day one wrap up this was pretty nicely run train. Everything got done. Lots of really good discussion. We are capturing comments. We'll be able to hopefully revisit some of these things that didn't get fully visited today. Same time tomorrow is when we're beginning. It runs a little bit longer because we have a little extra session at the end and an extra speaker. but it should be pretty good. If there are any questions on logistics or anything else, I hopefully we'll be able to get all those answered and fixed in time. But in the meantime, this has been really wonderful. I think I've learned a lot, and I hope we all have. And so, without anything else to say, I mean, we got people to stay 7 minutes late. That's insane. That never happens when I used to teach. So, but I'll talk to you all tomorrow. And thanks very much to the chairs, to Richard and to Beth for chairing their sessions and for keeping everything on track. It was really great. So thanks very much, and bye.